So once again, thank you everyone for joining us for the Best of ASCO 2021 virtual conference. Without wasting any further time, we'll move on to our first session. Our first session is on lung, and our first speaker is none other than Dr. Prabhat Singh Malik, who's a medical oncologist from New Delhi, and he'll be talking on the topic this day, that year. So without wasting any further time, over to you, sir.
Yeah, thank you. And good evening, everyone, and welcome to this academic feast, Best of ASCO 2021. Thanks to the organizers for giving me this opportunity, and thanks, Vamshi, for making me the opening batsman for this evening. I've been given the responsibility to discuss some of the key abstracts which have been presented in previous year ASCO, and to evaluate how they have influenced our day-to-day clinical practice and how these studies have stand the test of time. First of all, I mean, all of you are aware about this study. I think this ADAURA study would be the most discussed study over the last 1 year of 2020 and part of 2021. This was initially presented in ASCO 2020. And throughout this entire year, we have been debating whether we should accept this trial results, looking at the impressive DFS benefit demonstrated by osimertinib in adjuvant setting, whether we should accept it in our day-to-day clinical practice right now, or we should wait for overall survival data. Just to revise that this trial was a randomized phase 3 trial of resected non-small cell lung cancer, stage 1B to 3A, EGFR mutation positive, and patients who were eligible for adjuvant chemotherapy received adjuvant chemotherapy, and then they were randomized between osimertinib and placebo. And the treatment was continued till 3 years, or recurrence or discontinuation because of toxicity, and the primary endpoint was disease-free survival. All of you would agree with me that these kind of differences in survival curve are rarely seen in oncology. And this is one example within a very impressive hazard ratio of 0.17. But the median follow-up time at this time of this time point when the study was presented and the study was published was close to 2 years. And the data maturity was approximately 33%. But looking at the difference, it seems unlikely whether the difference would really lose on long-term follow-up. All the subgroups were benefited with adjuvant osimertinib. Overall survival data is pretty immature at this time point. Even like majority of the patients are still continuing on the study treatment, so it's too early to comment about overall survival data. And the study has already been published in New England Journal of Medicine. So why I'm saying this, whether we should take this study as a point of changing our clinical practice at this time, or we should wait for overall survival. Partly this answer lies in another study which was presented last year ASCO 2020, which was CTONG trial, which used adjuvant gefitinib, our old time-tested TKI, the first generation TKI in the similar adjuvant setting. This study was almost similar except for a few differences from ADAURA, which was like it included stage 2 to 3A. ADAURA included stage 1B also. And the large majority of the patients in CTONG trial were actually 3A. Here, patients who were randomized to TKI were not allowed to receive chemotherapy. In fact, the comparator arm was the platinum-based doublet. The treatment duration was 2 years. And what last year ASCO they presented was the updated overall survival results after a median follow-up of almost 18 months, which is a reasonably long follow-up time. And what you see that previously observed DFS difference with adjuvant TKI were actually lost, and eventually there was no overall survival difference because the large majority of the patients in the comparator arm eventually received TKI when they had recurrence or when they progressed. although the DFS difference remains significant. But what you see at the later part of the curves here, beyond 2 to 3 years, both the curves are actually merging, which again signifies the advantage of seeing these studies at the long-term follow-up. Although this post-hoc analysis of this trial does show that if you take adjuvant gefitinib for longer duration, that is more than 18 months, so these patients did have overall survival benefit, but this is again a post-hoc analysis. If you just compare these two studies and keep them head to head, more or less they are similar except for a few key differences. One is certainly the duration of treatment. There's 3 years in ADAURA and 2 years in CTONG. A large, almost two-thirds patients in CTONG were actually stage 3A, where only one-third were stage 3 in ADAURA trial. Chemotherapy was allowed in the TKI arm in ADAURA, while it was not allowed in the TKI arm in CTONG. Here, ADAURA, we are looking at in the pretty early phase because it's a follow-up time of 24 months. And in fact, the treatment duration itself is 3 years. But nobody can deny the amount of difference which it has created in terms of disease-free survival. Although we did have DFS benefit, which was statistically significant, although not so impressive what we see with ADAURA, with CTONG also, but it seems that overall survival, there is no overall survival difference when we see it at long-term follow-up. But still, the big question still remain unanswered, which one of them is certainly whether ADAURA would also have the same fate as CTONG in terms of overall survival when we look at this data again after a few years. We really don't know, but it seems unlikely looking at the amount of difference in DFS which has created. Certainly, it's just a better drug than gefitinib. Another thing is whether it's only the drug which has made such huge difference, or it's the duration which is making this difference. Still, something which we need to see after a long-term follow-up data. Then again, one thing which is unanswered, although ADAURA trial allowed adjuvant chemotherapy, but looking at the CTONG design and looking at the difference which was made predominantly by the TKI, is still questionable whether we need chemotherapy in patients with resected non-small cell lung cancer having EGFR mutation if we are planning to use a TKI in adjuvant treatment. There are a couple of new drugs which have been presented in last 1 or 2 years at ASCO, which has actually expanded our list of driver mutation which we need to test in any newly diagnosed non-small cell lung cancer patient. I would give two such examples. One is pralsetinib for RET fusion positive non-small cell lung cancer. This early phase data was presented last year, which shows an impressive objective response rates, and these responses were durable. Similarly, this Liberto trial was although presented earlier, but last year ASCO in 2020.
2 minutes left, sir.
Yeah, so they demonstrated the impressive intracranial response rate. Again, these intracranial responses were also durable. In last couple of years, we have been discussing about liquid biopsies and ctDNA, and in last 1 and 2 years, ASCO, there have been some studies which were presented and evaluated the role of ctDNA in assessing the minimal residual disease after curative intent treatment. In last year ASCO, there were two interesting abstracts which were presented. One evaluated ctDNA as MRD post-surgical resections, and it demonstrated that patients who had residual ctDNA post-surgical resection had inferior outcome. Similarly, ctDNA in driver mutation positive patients, particularly for EGFR mutation, the baseline allele frequency of these driver mutation could determine the prognosis of patients who are treated with TKI. This sounds an interesting strategy, but this is still questionable how useful it is in our day-to-day clinical practice, and how many of you are actually using it right now in your day-to-day clinical practice. We are not using that. There are certain obvious reasons behind it. I mean, we certainly it can differentiate patients who would have poorer outcome or a better outcome, but eventually how to treat them best is still something which is not really answered. There are a couple of ongoing studies which are evaluating role of adjuvant immunotherapy in patients who have residual ctDNA post-surgical resections. But once we have those data, probably that could have a larger impact on clinical practice. Certainly, there are reasons, technical reasons behind not using these strategies in our day-to-day practice. One is standardization and availability of the test. That's all from my side. Thank you very much.
Thank you so much, sir, for the wonderful start of the Best of ASCO 2021 virtual conference. We'll now move on to the abstract presentation. Our first abstract presenter is Dr. Sridhar Dasu, who's a surgical oncologist from Hyderabad. Over to you, sir.
Yeah, good evening, and I thank Dr. Vamshi for giving me the opportunity to present 2021 Best of ASCO abstracts. So my abstract is upon Violet trial, which stands for video-assisted thoracoscopic surgery versus open lobectomy in early-stage lung cancer. The one-year results, which was done by Eric Lim et al., based in UK. So the need for this trial is felt because there is not much level 1 randomized control data evidence to show that it is oncologically safe and superior VATS as compared to open lobectomy, especially in early lung cancer. And this is one of the reasons why even in UK, the utilization of VATS lobectomies is only about 60%, whereas in the United States it's less than 30%. So next slide. So this is a multi-center randomized controlled trial, which has had a parallel designs and included participants above the age of 18 years with a known as suspected lung cancer primary, clinically T1 to T3. Initially, it was T1 to T2, but based upon the 8th TNM staging, it was included patients who are also in T3, node 0 or node 1, and non-metastatic in a 1:1 ratio. People were randomized between VATS versus open lobectomy arm. And basically, there were two outcomes. The primary outcome was essentially a patient-reported physical function at the end of 5 weeks. That is how the patient felt after 1 month following a surgery. And the secondary outcomes, which is not mentioned in this slide, included the cancer oncological outcomes like disease-free survival, overall survival, the number of patients who were pathologically upstaged to N2 after the surgery, the health-related quality of life, the efficacy in terms of post-operative pain, and also the in terms of the number of cost-effective analysis. So the next slide. So we can see that the physical function, which was studied by using the URTC questionnaire, QLQC 330, it was found that the mean difference was statistically significant in favor of the VATS arm at the end of 5 weeks, and it was also sustained over a period of almost 6 months to 1 year. Next slide, please. Yeah, and in terms of in-hospital pain, because the analgesia was as per the institutional protocols, it was found that there was no statistically significant difference in the pain control. There was only less use of opioids favoring VATS at the end of post-operative day 1 and post-operative day 2 in favor of the VATS arm. And the next slide. So also the procedural safety in terms of any hospital-related adverse events. You can see that there is almost a 12% decrease in the adverse events in favor of the VATS arm as compared to the open surgery arm, proving the safety as well as the efficacy of VATS lobectomies in good centers with high volume places. Next slide. In terms of the overall survival as well as the disease-free survival at the end of 1 year, we can see that the hazard ratio is almost close to 1, which is not a non-significant p-value. So there's no difference in the overall survival or at least disease-free survival in terms of VATS versus open. Next slide. So the conclusion was that VATS lobectomy is associated with less pain, significantly lower total complications as mentioned by the adverse events, lesser length of hospital stay with no compromise to oncological outcomes in terms of lymph nodal yield, mediastinal clearance, superior recovery times, less complications, less readmissions, and a technique that is both more effective and less costly compared to the thoracotomy arm. So certain strengths about this trial is that first, it is a patient-centric trial because most of the VATS arms only take in terms of the surgeon's perspective, that is in terms of the size of the incision, the number of days in which drains are used or not. But this is actually a patient-centric where in which the health-related quality of life, especially at 1 month, and return to function is checked. The second thing is that The opportunities are that because definitely in future we are going to use the VATs, especially in the developing countries like India. So the cost benefit analysis is going to make a big difference to this. So can you hear me?
Yes, sir, we can hear you, sir.
Yeah. So I think that concludes my abstract.
Thank you so much, sir. We'll move on to the next abstract. Our next presenter is Dr. Sujanna Priya, who's a radiation oncologist from Hyderabad. Over to you, ma'am.
Yeah, can you hear me?
Yes, ma'am, we can hear you.
Yeah, good evening, everyone. I want to thank everyone for giving me this opportunity. I'm Dr. Sujanna Priya, radiation oncologist, working in AIG Hospital, Hyderabad. So today I'll be talking about a phase 3 comparison study of high dose once daily thoracic radiation versus the standard of care, twice daily radiation in limited stage small cell cancer. This trial has been published by, it's a multi-center study. Trial has been published by Dr. Jeffrey Bogart from Syracuse Upstate University, New York, SUNY Upstate University, New York. Next slide, please. So coming to the initial schema of the trial, in a limited small cell, they have taken 3 arms. Initially, it started as a 3-arm study. So the arm 1 is the 45 gray twice daily dose over 3 weeks. And arm B is the 70 gray dose over 7 weeks. We treated 2 gray per fraction around 35 days. So arm C is 61.2 gray. That's a concomitant boost arm over 5 weeks. So that's the arm C. So along with this radiation, there is a chemotherapy backbone with cisplatin and etoposide, which is given every 21 days for 4 cycles. So as per the trial protocol, thoracic radiation is to begin with the first cycle of chemotherapy. Next slide, please. So the trial, this CalBG trial, the accrual details, it has been activated in 2008. So in 2012, there's been an interim analysis of toxicity between arm B and arm C. So after they didn't find any non-significant difference between arm B and arm C, so they dropped arm C, the concomitant boost arm, and they proceeded with only 2-arm study. The accrual was completed in 2019. Next slide, please. So the initial idea was to accrue around close to 700 patients, which have almost closely they have done. So it's a 2-arm study now, almost accrued 638 patients. So most of the patients, almost around 60% of the patients have underwent IMRT technique. Only 40% of the patients underwent 3D CRT. So most of the patients, almost 40 to 45% of the patients took chemotherapy along with the start of the radiation, first cycle of chemotherapy. And most of the patients had, almost 80% of the patients had cisplatin chemotherapy as their backbone, barring 20%, maybe because of various other reasons. Next slide, please. So coming to overall survival, which was the primary endpoint for analysis, just to compare which is better between the arm A and arm B, there was not much of a difference. Arm A had a median OS of 28.5 months, and arm B had a OS benefit of 30.5 months. That's the comparator arm. So if you see the p-value, it's not quite significant. And even if you see the confidence interval along with hazard ratio, it tells the same thing. Next slide, please. So coming to the PFS benefit, if you see a statistical test of difference also, it didn't show much of a benefit, at least in the first 60 months. So after that, you can see a little bit of flaying of the curve, but that can be attributed for different reasons. But at least in the first 5 years, the PFS benefit is like not much statistically different between both the arms. Next slide, please. So in conclusion, the CalGB trial failed to prove that 70 gray is superior to 45 gray, the standard of care arm. That's the BID dose. Twice a day, we usually treat with thoracic radiation. So, but coming to the outcomes, if you see in the recent past, if you can assess the high dose radiation arm, the outcomes are, it's the best available evidence in the high dose once a day radiation arm, 70 gray arm. So, I mean, when we start from taking from the historical perspective, and we start from the Curacy preliminary report, so there's been a lot of radiobiological rationale as to why this 45 gray twice daily dose has been actually given. So it started with only 23 patients in 1988 from University of Pennsylvania. It's published by Dr. Curacy. So I think even a few trials of dose escalation have not proved to be that beneficial, like the CONVERT trial, which was published in 2017. So I think that concludes my abstract presentation for today.
Thank you so much, ma'am.
Thank you. Yeah.
We'll move on to the next abstract. Our next abstract presenter is Dr. N. Aditya Murli. He's a medical and hemato-oncologist from Bangalore. Over to you, sir.
Thanks to organizers, thanks to Vamshi, and thanks to Purik sir for having me on board for this Best of ASCO meet. So what I would be presenting over the next 5 odd minutes is another trial from the IM Power basket. This is the IM Power 010, which is a primary results of a phase 3 global study of atezolizumab versus best supportive care after adjuvant chemotherapy in resected stage 1B to stage 3A non-small cell lung cancer. Next slide, please. Next slide, please. Yeah. So basically, this trial was designed as a logical extension of how all the new drugs progress. So most of the new drugs do come into the metastatic setting, and then once they have good proven benefit, we want to try them in the adjuvant setting, and that's how osimertinib came into adjuvant setting. And I know that the session opener was all about osimertinib and adjuvant setting and all these things. So this trial talks about immunotherapy in the adjuvant setting, and this is a particular subset wherein immunotherapy has not been able to make too much of a difference. So the salient features here are stage 1B to stage 3A were included. The patient could have received any of the chemotherapy protocols earlier. Post chemotherapy, patient was stratified 1200 milligram every 21 days for 16 cycles versus best supportive care. Interestingly, the primary endpoint actually was investigator DFS in stage 2 to stage 3A population with a PDL1 score of more than 1%. Next slide, please. So this slide is the Kaplan-Meier for the DFS in the PDL1 TC score of more than or equal to 1%, stage 2 to stage 3. So this was the primary endpoint. And in this was a blockbuster success, unqualified success in the sense that the hazard ratio was 0.66. We could see the curves were separating quite early as 4th, 5th month, and then the benefit continued. In fact, at the 3-year mark, we had 60% of patients who were still disease free, which is which is path breaking for adjuvant treatment in non-small cell lung cancer. Next slide, please. So when we looked at the DFS in all the randomized stage 2, stage 3A population, and this was also one of the primary endpoints. In this, the hazard was probably not as spectacular as the PDL1 positive subset, but nevertheless, this was a this had a hazard of 0.79, which is statistically significant p-value, which probably goes to show that even in this setting, there is a benefit with ATI. Next slide, please. When we looked at the actual intention to treat population, which included the stage 1B subset also, here is where things got a little confusing or murky. The DFS did not meet the pre-specified, did not cross the significance boundary at this interim DFS analysis. Next slide, please. So this slide talks about the OS data. The important thing to note is OS data was probably still premature. It was immature at this pre-planned DFS interim analysis stage. The OS in the intention to treat population was not formally tested also. But if we want to try and tease some details out, there was a trend towards OS improvement with ATI in the PDL1 TC score more than 1% population. Next slide, please. So this trial concluded that this was the first phase 3 study of cancer immunotherapy to demonstrate DFS improvement in the adjuvant setting non-small cell lung cancer after platinum-based chemotherapy. Adjuvant ATI following complete resection and adjuvant chemo showed a statistically significant DFS benefit, especially in the PDL1 TC score more than 1% stage 2 to stage 3A population with hazards of about 0.1. And in all the randomized stage 2 to stage 3A with a hazard of about 0.79. At this pre-planned interim DFS analysis, OS data was immature and not formally tested. ATI may be considered as practice changing adjuvant treatment option for patients with PDL1, TC score more than 1%, stage 2 to stage 3A non-small cell lung cancer. Last 30 seconds for my take on all of this. One is this is definitely a clinically significant trial. But as Dr. Vamshi Krishna said, I think we should restrict to stage 2 and stage 3 and not stage 1B. So that was one of the things. The second thing I would like to point out is that if a patient is EGFR mutant, then maybe osimertinib might be a better choice than immunotherapy. And final point is, in a curative cancer, we need a OS benefit. Without that, it's difficult. Thank you. Thank you, organizers.
Thank you so much, sir. Before we move on to the next session, on behalf of our program director, Dr. M. Vamshi Krishna, and also the organizing committee, we thank our scientific committee advisors. Thanks to their support, we are able to choose the best abstracts for the conference. We give a special thanks to Dr. Anand Ramaswamy, Dr. Ashish Singh, Dr. Purvesh Parikh, Dr. Randeep Singh, Dr. Shujit Kumar, our next moderator, Dr. Ulas Batra, Dr. Vijay Patil, Dr. Vinayak Maka, and Dr. Viraj Lavingya. So with that, we move on to our next session. Our moderator is none other than Dr. Ulas Patra, who is a medical oncologist from Delhi. His panelists are Dr. K. Sarvanan Raja Manikam, surgical oncologist from Namakkal, Dr. Sayan Paul, radiation oncologist from Hyderabad, Dr. Amish Vora, medical oncologist from New Delhi, Dr. Nitesh Rohadki, medical oncologist from New Delhi, Dr. Vivek Agarwal, medical oncologist from Kolkata, and Dr. Aju Matthew, medical oncologist from Kochi. Over to you, sir. Sir, please note Dr. Nitesh might not log in, sir.
Okay, fantastic. So thank you, and thank you, Vamshi. Thank you, Kavina Creations, for giving me an opportunity to moderate. And I think this is the first instance, where you actually feel that the panelists are much more brighter than the moderator actually is. With names like Amish and Vanita coming and sitting next to this over there, I'm the only black spot, I guess, in the entire moderation of this early stage panel on cancer. One more trivia which I will tell you. Yesterday afternoon, Dr. Amish called me up and said, are you going to discuss all three abstracts? So this is again one instance where the panelist is much more prepared than the moderator is, because moderator started preparing only yesterday night. So let me start. Panel discussion on the early stage lung cancer. And my first reactions, when I first saw these three abstracts which were there, by the way, none of which was selected by me, Vamshi. I know I think you know the reason why. Only one was selected. Was this. I imagined a picture of Dr. Vanita Naroha sitting lazy, idle, and on something and saying, everything else is sorted out in life. CRST theek chal raha hai, Tata theek chal raha hai, stage 4 clear ho gaya. Now let's talk about high dose and low dose radiotherapy in small cell lung cancer. Let's talk about lobectomy versus VATS, and let's talk about adjuvant immunotherapy. My first reactions. I can see the smile on Amish's face right now over here. Amish, there's something for you also. Just wait. So let me start with the fun things now. This is the second abstract which was presented, which was the phase 3 comparison of high dose once daily thoracic RT versus standard BD TRT in limited stage small cell lung cancer, CALGB Alliance versus RTOG trial. And let's start with the critical analysis. Can I get Dr. The radiation oncologist on the board, Dr. Saya? Is this trial design an unmet need or clinically relevant?
Yes, I do feel it is very, very relevant, because as we know that we just follow the twice daily schedule for this early stage small cell lung cancer, but the BABD dose, that is 2 doses per day. But actually, truly speaking, this has a lot of logistic issues. And I know that most of the centers, even in India, they do not use this BD schedule. Rather, they are using once daily schedule. But we don't have a strong evidence for that. The CONVERT trial, that was a superiority trial actually. So they tried to establish 66 day in 33 fraction, but they could not establish. I mean, it was.
So, Dr. Sayan, in short, you feel that this was an unmet need. This was a clinically relevant question which begged to be answered. Fantastic from the radiation oncologist perspective. Dr. Aju Matthew, do you think small cell lung cancer for a medical oncologist, the second or the first abstract being presented, clinically relevant, or theek hai, ho bhi gaya to ho gaya, nahi to we will listen to something else. Something better is coming up.
It doesn't matter. Let me wait for the better one coming in.
It doesn't really make a difference. So a medical oncologist and radiation oncologist are loggerheads once again. Dr. Vivek? Vivek Agarwal is there?
Yes, sir, he hasn't joined with device audio.
Okay, fantastic. So we have Amish. No issues with that. Amish is there. And then, so there are one is to one split is there. We will take Dr. Amish's opinion, and then we have Dr. Vanita Naroha, if she can give me her final comments on met or unmet need or not. So, Amish.
I think 45 grays in 3 weeks versus 70 grays in 7 weeks there is a huge logistic issue here. I personally think is 45 gray twice a day has been whatever I have read since yesterday. I called you Ullas. I think that has shown to be superior to other once a day INT 006 trial or something like that. And this trial says that both are equal in terms of OS. The centers which can do twice a day, I think 3 weeks is much comfortable to patient compared to 7 weeks of daily Monday to Friday coming and high dose of radiation once a day. That would be my medical oncology 3-mark short note on radiation oncology requirement.
Okay,
now, Vanita
fantastic.
will give me marks out of 3.
So I will ask Vanita a different question. Vanita will give you 3 on 3. Vanita will give me 0 on 3, first of all. So Dr. Vanita, and then to the radiation oncologist, Dr. Sayan, do you really think that, what we had over here, the 45 gray BD in 3 weeks, is the standard arm really a standard of care? So Dr. Sayan, in your small cell lung cancer last 5 years, let's take a show of hands. How many have you given 45 gray BD along with etoposide, carboplatin or cisplatin?
Yeah, so mostly probably it will be around 60% and 40%. 60% patients are treated with BD dose and
Okay.
like 40% with OD dose, because it's difficult for the patient to come twice to the hospital, and
Okay,
that too with
fantastic.
6 hours of gap.
That's
And you have to space them like early morning and late evening. So
yeah, there has to
coming
be at
twice,
least an 8-hour gap between the two.
yeah,
Okay.
6 hours gap. So that too, it's a bit problematic. I do find it a bit problematic.
I can stick my neck out and say that, in Rajiv Gandhi, we do not actually, very rarely I would remember a young patient who actually has gotten a 45 gray BD because mainly of the side effects of radiotherapy actually. Dr. Aju, what is your take?
Well, BD is impractical for almost all of my patients.
Okay. Okay.
So
So
I think
1:1 once again. Amish, you are the tiebreaker or tire breaker once again.
Again, as I said, that radiation oncologists know their practical issues better than us. But as you rightly said, Ullas, first of all, limited stage small cell lung cancer last dekhe hue jamana ho gaya hai. But whatever I remember, it was always once a day program from the radiation oncologist.
Fantastic. Dr. Vanita, if you are still listening and in the mood to answer me.
No, I'm here.
Yeah, I know, Dr. Vanita.
I was not expecting you to ask me for your panel. Yeah, I just
I
came
told you this, Dr.
be
Vanita, a long
educated.
time back, at one of the conversation that I'll catch you sometime in between, And
Yes,
you be grateful that I'm not putting out the telephone conversation in which you scolded me on the thing over here. I'm telling you this. Tell me, Dr. Vanita.
No, so I'm very impressed at Sayan giving 40-60. Yeah. I think even in the US, there is not that much of uptake of that convert regimen. I must say in whatever 9 or 10 years at Tata, there's not a one patient that we have treated with BD dosing. It's always been the single day dosing. But I think this is a practice reaffirming study that giving it as once a day dose is actually you're not harming the patient and the outcomes are similar.
Okay, so Dr. Vanita, I would ask the medical oncologist if there is so much of benefit, we medical oncologists are often blamed, that for every 2% benefit, we will change our practice. For 6 weeks, we put gemcitabine into CA pancreas. Then what is the problem? Why we have not really, jumped the gun and given the BD dose?
It's logistics. I know when the convert data came out, we were all very impressed and we sat down and discussed with our radiation oncology colleagues and they said it is just not doable. You need to have that break. What happens? Where does the patient go in between? What happens to the patient? Goes home, comes back. It's just not practical.
And the side effects, the high incidence of esophagitis and all, which is there, also has to do a lot with that. Dr. Sayan, can I ask you your comments on this? The contralateral hilar or contralateral supraclav, supraclav, so we agree, but the contralateral hilar lymph nodes were excluded. Your take on that?
Yeah, contralateral supraclavicular nodes are excluded. That means from the elective nodal volume, we are not treating any elective nodal volume. Let me read
is this what you do in your clinical practice? Is this all right? When you treat small cell lung cancer, my gut feel is radiation oncologist will include the contralateral lymph nodes.
Yeah, that's fine. That's fine. If they have excluded it, then it is okay. That's no problem in the design. I don't find any problem.
Let's go to the next one, which I thought was interesting. Amish, this almost looks like my story. Activated in March 2008, arm C dropped in March 2012, completed in December 2019. Well, is there any problems with this design and the results from it?
I think they checked about the side effect profile in that booster dose, and they found that arm C they need to drop it. I think it's fair enough. It's a very honest decision, and
that's okay. But what about 11 years to accrual?
They have completed the study in December 2019, and how many of us like you would have seen 100 cases of non-small cell in last 10 days? How many early stage small cell you would have seen, Ullas?
True that.
So let's look at that aspect also. So I think fair enough. It's fair enough.
It's fair enough. Aju, your take on this?
I'm not an expert. I'm going to pass.
I totally agree. And I would say, it is a difference between working hard and working hardly. It is almost like a difference between Kumar Prabhash and me. So maybe, this trial was designed by me and not by Kumar Prabhash. That is why it took around, say, some 12, 13 years to, get up from there. Okay. The PFS curves lying on the top of each other, the OS curves lying on the top of each other, and the adverse events profile. There were grade 5 events, more in the arm B versus the arm A. Any talks on that? Dr. Sayan, your comments on that?
Yeah, I mean, I actually cannot justify this, whether it is more in the arm B and not less in arm. I mean, I need to read the paper thoroughly. I need to know what are the reason of the death. Yeah. Because it is like, I can't explain it clearly.
I totally agree with you. So Dr. Aju, your take, you will use this regimen, the high dose regimen in your clinic tomorrow?
No, I don't think so. Nothing convinces me to change my recommendations.
Nothing convinces you. Dr. Amish, would you change your practice based on these results?
Again, apart from practical issues of giving twice a day, I'm not seeing or I'm not hearing any other issue. You kept on saying about esophagitis more being in twice a day, but like Vanita told, last 10 years, they have not used twice a day, mainly for practical issues.
Okay.
So unless and until we use it routinely, it's very difficult to say. This trial is a randomized trial. It shows there is no difference in OS or PFS, and there are more patients who have died in the single day long dose, high dose arm compared to twice a day arm. Unless until we have our own practical experience, it is very difficult to comment. Na?
Okay, so I think we are running short of time, and I want to discuss the blockbuster trial that was said by everyone in the chat box. I think the ways to improve survival in the limited stage SCLCs, decreasing dose of RT, I think we have come to that. I think a BD dose, if some fit young patient can take, that's okay. Intensification of current chemo regimens, I don't think you have to do with that. Addition of immunotherapy, a Pacific trial in small cell lung cancer, that's where I think the major improvement is going to come. Neoadjuvant strategies, I don't think is going to come. And this is a trial which is the Adriatic trial, and this is the Adriatic trial which is going on at us, where we are giving people who have small cell lung cancer after chemo radiation, we are going to randomize them to Durva, Tremi, Durva or placebo. I think this is where Allah Pacific, which is really going to help us in improving the survival of a small cell early stage lung cancer. So my conclusions, definitely we need to improve survival in limited stage small cell lung cancer. The current standard of care is imperfect. Nobody really gives a BD RT dose, at least in India in my setup. The trial failed to demonstrate the superiority of high dose RT over BD course RT. We need to look at the newer strategies for improvement in survival. And if I really have to say it in pictures, I would say these are the 11 clear signs that Dr. Vanita doesn't like me. No, it is not that. It is the 11 clear signs that in the limited stage small cell lung cancer, they do not like the high dose RT. That is my take on this trial. Now, let's move on to the other trial. And we have VATS, and I also see Vivek Agarwal has joined over here. This is VATS versus lobectomy. And we have Dr. Raja Manikam over there. So can I just, my first reaction again on this was, I think VATS versus lobectomy, VATS is something which is very standard with us. And my first reaction was, it's been done before. So what's new? The highlights of the trial, as the presenter told, were, the early outcomes were reported in WCLC, less pain, fewer complications, shorter LOS, no difference in early oncological outcomes, and there was superiority of VATS over lobectomy. So let me go to the surgeon, Dr. Raja Manikam. What is your take on VATS versus lobectomy and this trial? Since we have to discuss Empower 010, I'm going to rush through this trial.
Okay, so in our institution, we are almost 90%. Last year, we did around 90% of minimal access lobectomies versus only 10% of. And I think most high volume centers will give you the same picture, but that is not the story here. The story we need to hear is that in the entire country, if you see, it's almost the reverse. 90% of surgeries outside of high volume centers are done in the open fashion versus 10% being done in the minimal access fashion. And this is not only in our country, but also in Europe and America as well. And there has been no randomized trial from Europe to substantially, using all the, with current era technology and instrumentation to compare VATS versus open. And that's why this trial is very important, the Violet trial.
So I think this trial conclusively proved that VATS was equally efficacious oncologically while having a much more better quality of life for the patient. And to me, yes versus no for the surgeon, Dr. Raja Manikam?
Definitely yes. If it is
definitely yes.
In your hands, if VATS is safe, yes.
In your hands, don't say in my hands. In my hands, even a cutting knife is also not safe.
So it's actually the surgeon who should decide if in their hands VATS surgery is safe. Yes, they should proceed with VATS.
So, Amish, I am not even asking you yes or no. Aju, we are not even asking you. If the surgeon says yes, we are going to say yes.
Yeah.
But still, my conclusion I have to give, I'm the moderator, Dr. Raja Manikam, because pardon me if I'm wrong. I think MIS approaches are absolutely right. Large retrospective data was there, but this is the first randomized trial which has actually shown that MIS surgery VATS is equal to and maybe better than the lobectomy. It does establish better than that. It does establish VATS as standard of care. So definitely for me, the answer is yes, yes, yes. And again, as picture says a lot of words, this is what I would say. This is the surgeon and the patient. This is a general surgeon, Dr. Raja Manikam. This is not you. This is a VATS. This is the surgery and the patient in early stage lung cancer. So a thumbs up to you. But you should also remember the two supporting actors over there, which is the adjuvant and neoadjuvant target therapies and adjuvant and neoadjuvant immunotherapies, which we are going to come to. You may never know. The supporting actor may just replace the final actor over there also. That brings me to the elephant in the room. And I am not talking about me and Amish. I am talking about the Empower 010 trial design. So let's start with Dr. Vivek Agarwal has joined, I guess. Vivek has joined. Yeah, I saw his name somewhere over here.
Sir, he has poor net.
Okay, doesn't make a difference. So when this trial was being presented, the words were used were blockbuster, legendary, fantastic trial, a change of game. So Aju, what do you think about the study design?
The study design, I'm not sure whether stage 1B is a right population for this kind of intervention, but I'm not an expert in this that I can commentate on that. Okay. But if I were to hedge my bets, I would have focused on stage 2 and above.
Okay. Yeah. Amish, your take?
The results, they have focused on stage 2 and stage 3A, if you see. And I think they have taken more than or equal to 4 centimeter because all the meta-analysis of adjuvant chemotherapy, the cutoff is 4 centimeter. And they wanted to include all patients for chemo, and they wanted to check atezolizumab after chemotherapy. So that's the reason I understand the authors have taken 4 centimeter as the cutoff.
Fantastic, which is absolutely right. And my take on this is absolutely right. My take on this is, first, you are not going to eliminate chemotherapy from an early stage lung cancer, at least. That's my first take. The second take, which I actually thought was there was no crossover. It would have been great if there was a crossover, people on progression, if they would have got immunotherapy, we would have finally got an OS data on that. The third was, it was the DFS, and I'm going to come to the DFS debate. And one more thing which was there was 1 to 4 cycles of chemotherapy was given. So somebody could take 1 cycle of chemotherapy and then come into the trial. So these are some of the fallacies that I just saw at the trial. This was, yes, Anju.
But the fact that there is no crossover, I probably give them credit for that.
Okay.
That is my way
they may get a, but ethically, I don't know how many will they get. How many people actually
they
get a
will probably
crossover?
get a cleaner data at the end of
it.
So why do you require a crossover? What is the Ullas? What is
on
the
progression?
rationale
On progression. Sorry, not crossover. On progression, I would say. But did everybody get the same regimen, chemo, immuno, or something? That is what I wanted to ask. But just leave it on that. I think we have 5 more minutes remaining for that. 1 year ago, this was the DFS curve which came over there. The ADAURA trial, and there was a lot of criticism of ADAURA also at that time, even with the HR of 0.17. Now let's start with the DFS versus OS debate. There are only 2 of my panelists over here. So I'll go to Aju first, then Amish, and then we'll ask Vanita. Do you think DFS is good enough? Good enough is the new perfection? Or Amish, good enough is not really good enough? So Dr. Aju first.
Yeah,
the DFS versus the OS debate.
In this question, in the lung cancer world, I think DFS, I'm happy with the DFS as an endpoint.
So you believe DFS is the new perfection. You're good enough. I thought I will comment on that by saying test match. You have first innings, second innings, third innings, fourth inning. You're happy seeing the results of the test match after the first innings. That's what Aju is saying.
Amish, your take.
No, I think I agree with Dr. Raju. Even in kidney, where the pembrolizumab data is there, in the lung, when there is atezolizumab data is there, both are actually the unmet needs, because you don't have anything. Here, the only issue what I feel, and the great Dr. Nitesh Rohatgi has joined. Now, what more do you want? But I will speak whatever I want to speak before Nitesh. See, in this trial, Ullas, they have not specified how many of them were EGFR mutated. Assuming 25 to 30% of, assuming 25 to 30% of them are EGFR mutated, and if you take them away, I feel that atezo with this DFS data, I am okay.
Okay, so DFS is good enough for
DFS, OS, but I am okay right now in lung cancer with DFS. Yes.
Nitesh, DFS is good enough for you? Yes or no?
Not in this study.
Not in this study, but in ADAURA study. Roche is not convincing you. AstraZeneca has convinced you. Tell me why.
No, I don't think it's that. I think we have to first look at the benefit in the metastatic setting.
Okay.
Your benefit in metastatic setting or your PFS benefit in metastatic setting is X. I think it would be wrong to look at your OS survival at least 2X, if not 3X.
Okay, so in your opinion, the benefit is not very good, and I'll just quickly go over here. The benefit that you were talking about, Amish, I'll take your comments on this. These were the 3 statistical hierarchical design. The first one, the HR was 0.66. The second one was 0.79, then 0.81. The last one not significant, so they are not going to formally test for OS. Happy, Amish?
So just to what Nitesh said, I am not asking question because that is your domain. I'll very quickly say the hazard ratio of adjuvant chemotherapy, Nitesh, if you remember, 0.84, and all patients above 4 centimeter, we are giving chemotherapy.
Yes.
And here the p-value highly statistically significant. You do TC if they are more than 1%. At least I would offer adjuvant immunotherapy. If patient can afford, if they anyway.
That's okay. Nitesh is totally on the blue side of it. Nitesh wants to give adjuvant immunotherapy to everyone. Aju, skeptical, somewhere in between?
A tough disease, a very valid drug for this disease. I'm convinced DFS is sufficient for this.
Okay, so Aju is also on the blue side of it. Second one, Nitesh.
But again, let me add. I'm forgetting the cost part of it. Okay.
You're forgetting the cost part of it. Absolutely. When you have Nitesh and Amish, you don't think about the cost. They actually fund this treatment over there. So Nitesh, your take on this.
I still am not convinced.
You are also not convinced. You would want to wait for the OS data.
I would want to wait for data because the tails of these curves are very long, even in metastatic setting. And that's what I was trying to say. That when the tail is very long, you have to be careful of DFS data in the adjuvant.
Fair enough. Nitesh, you would want to wait for the OS data. Nitesh, I would want you to look at this. Now, this is TC more than 50, TC more than 1, and TC less than 1. You see something? You smell a rat over here? Oh no, you're happy. Everybody said PDL1 more than 1% is okay. Amish said that.
No, I think we keep analyzing these. We have a lot of forest plots. We've seen them in many studies and we've seen them fail in OS data. So I don't think these will be good enough to change.
My take on this, Amish and Nitesh and Aju, and I think if Vinita can come up, see, there is no data of 1 to 49. So more than 1 also includes more than 50%. Is this very smartly, this trial, they have not told us the data of 1 to 49. I would like Vanita to come in if she, I'm sure she must have critically analyzed it all together now. And my take also is here is it the keynote 42 movement of, this was the Pembro approval for PDL1 more than 1%. And if you see over here, the majority of the benefit was given by PDL1 more than 50%. So, is this the keynote 42 of adjuvant setting? Amish, Nitesh, Aju, and Dr. Vanita. Anyone can come in. Because they didn't tell us 1 to 49.
This is classical like head and neck cancer. Na? In head and neck cancer also, Pembro plus chemo versus Pembro alone, if you really see, the majority of the benefit was driven by more than 50% because more than 1% included more than 20%.
Yep. So
but,
my take on this actually is...
These are all conjectures. These are all conjectures, Ullas. I feel that let's look at the data and let's signify rather than assuming what happens.
Okay. I am not going to discuss because I already have got a message that it is last 2 minutes. But my conclusion on Empower 010R, it's a well-conducted trial, large number of patients. It's the first trial to show some advantage of immunotherapy in the early stage non-small cell lung cancer. It improves the DFS. There is no benefit in PDL1 negative. Benefit in PDL1 to 49, I'm not sure. I probably may not give it for a patient who has got 1 to 49. Let's wait for more data. There were no new safety signals reported. Maybe the first early steps of immunotherapy in early stage non-small cell lung cancer. We need more data. And again, if I have to put a picture onto this, this is what immunotherapy is proposing to the adjuvant setting of non-small cell lung cancer. So Amish, what should the girl say? Yes or no? Fast. Yes or no?
You just go ahead.
Nitesh, what should the girl say?
No.
Aju, what should the girl say?
Let it snow.
Okay, Vanita, Dr. Vanita, what should the girl say?
Possibly yes, based on what the patient wants.
See, that is what I always agree with Dr. Vanita. I would say yes, but with terms and conditions, you know, पापा को मिलना पड़ेगा, 8 बजे के पहले आना पड़ेगा, ये नहीं करना पड़ेगा, वो नहीं करना पड़ेगा. So I would say yes. In a stage 3A, PDL1 more than 50%, I would be probably inclined to give. Lesser stage 2B, probably in a PDL1 10, my personal take is I may not be able to do. With this, I come to the end of my moderation. I used to start my finish my presentations with, hope being in lung cancer. Now I have switched over to lung cancer deserves a cure too by immunotherapy. And in the end, congratulations, Dr. Senthil and Dr. Suresh for being included in the ESMO head and neck management guidelines. And this also goes on to show that I have just made the slides today. Thank you. And move to the next session. Thank you.
Thank you so much, sir. We'll move on to the next session. This session is sponsored by AstraZeneca. The topic is EGFR positive metastatic non-small cell lung cancer patients managing complex cases. Our moderator is once again Dr. Ullas Batra, a medical oncologist from New Delhi. His panelists are Dr. Mudassir Ahmed, medical oncologist from Noida, Dr. Shruti Kate, medical oncologist from Nasik, Dr. Rajesh Bolam, medical oncologist from Hyderabad, Dr. Amit Sherawat, medical oncologist from Rishikesh. So Dr. Nikhil Pandey has not joined. We'll inform you once he joins.
Okay, fantastic. Can I share my screen once again? Okay, here we go. Okay. Unfortunately, you guys will still have to, listen to my stupid discussions in the next 20-25 minutes also. Mudassir is looking very smart over here. And what I have been asked to moderate for the next one is EGFR positive metastatic non-small cell lung cancer patients managing complex cases. So again, as I started, my first reactions on this when I saw the topic basically was, oh my God, complex cases. How are we really going to discuss this? And then thought, with the panel that we have over here, together we definitely will be able to find the answer to the complex cases. Then I read my subsequent reactions were I read my brief again in detail, and I found it's a sponsored session. And what Astra wants me to discuss over there is, we all know, osimertinib, osimertinib, osimertinib. So I thought, what we will finally do is, we are going to split up. For the initial 10 minutes, we are going to discuss about boring first-line EGFR mutant non-small cell lung cancer. In the last 10 minutes, I am going to tell you some real interesting complex cases, and I would ask everybody to join up over there. So let's start with a case scenario. The first 10 minutes goes to AstraZeneca sponsored session. So let's start with this case. You have a 60-year-old female who comes with a history of cough and breathlessness, PET scan done, which basically shows a lot of nodules, liver and bony mets. ECOG PS1 lab parameters are normal. The biopsy from the lung mass shows adenocarcinoma. Dr. Shruti, I'll ask you first. How do you perform biomarker testing in non-small cell lung cancer? Do you go the sequential way, reflex testing, small panel NGS, the coupon NGS as I call them, the large panel, the foundation panel, liquid biopsy? How do you want to go ahead? Dr. Shruti? Okay, I think she has dropped out. Mudassir, I can see you here.
Sir, yeah. Sir, I think we have discussed it previously also. I prefer the NGS broad-based panel because of the broad base, so I get all the information upfront. The disadvantage is that it may sometimes take time, and sometimes if I have enough tissue, I may do the EGFR and ALK and ROS separately again. If I have enough tissue.
Okay, so Dr. Mudassir says the lung cancer, the broad panel NGS, the 50 gene panel, at least that is what you do. Dr. Shruti, what do you do?
Sir, I also do the broad panel NGS for all patients.
Okay, and how long do you get to take the report?
So it's almost around 2 weeks. So
around 2 weeks.
If the patient is symptomatic, I do start on chemotherapy.
Okay.
And wait for the report, but I do send NGS for all patients.
Okay, you do send NGS for all patients. Fantastic. Yes, I'm sure Dr. Vanita and I am the only two people who are not sending NGS for everyone. Dr. Vanita, can I ask you your take? NGS panel for everyone? Are we living in US or are we living in India?
I think even in the US, the uptake for NGS for all patients is less than 50%. And in first line, it is like 30%. So hats off to you, Shruti, that you are managing this. And the setting of practice varies, but certainly in our setup, it is not all patients.
Even with my setting, Dr. Vanita, I mean, okay, we also are semi-corporate, semi-private suits when it is difficult to send NGS for everyone, but hats off to you guys. Dr. Rajesh Bolon, what is your opinion on this? Dr. Rajesh has not joined in. Okay. Dr. Nikhil? Okay. Okay. So let's go from here. This patient, Dr. Shruti, came as EGFR del 19 positive. Her ALK was negative by IHC. The ROS was negative by IHC. The PDL1 was 90% by 22C3. What would you do? Trick question.
I would start the patient on EGFR therapy.
You will. Okay. It doesn't make a difference. The PDL1 can be whatever it wants.
No,
Okay, I seem to have missed. Dr. Mudassir, can you hear Dr. Shruti? No.
No, sir, no.
Okay, I think, okay, fine. So this is just to show, this is our paper that we presented and was published this time when we said EGFR and PDL1 was an interaction between EGFR and PDL1 and there was no interaction. Even in the PDL1, even if it was 0%, 10%, 100%, the efficacy of EGFR TKIs actually did not decrease. So this is our data set, which is saying the same thing. This is what the treatment options which are available for EGFR mutant non-small cell lung cancer. And this is EGFR mutant non-small cell lung cancer. This is osimertinib. This is sequential TKIs. This is TKI combos followed by osimertinib. This is on the extreme left is Vanita Naroha trying to get people to give chemo and TKI combos. So we definitely are spoiled for choices. So let's get the finances out of this equation. Dr. Mudassir, what would you do? Okay, I'll start with this. I'll start with this question first. Do you think the treatment of EGFR mutant non-small cell lung cancer with first generation TKIs in 2021, this was Dhoni before and this is Dhoni now, do you think it's suboptimal?
Sir, I certainly feel that it is suboptimal, at least with the TKI first generation.
Okay, so you think it's the Dhoni of old. You want the new Rishabh Pant to come in over there.
Correct, sir.
Correct. Fantastic. Dr. Shruti? Dr. Shruti is not. Dr. Amit Shahrawat?
Yes, sir. Can you hear
me?
Okay,
yeah, Dr. Shruti.
Yes, sir. So I definitely feel that first generation TKI is suboptimal. So if there is a place anywhere for the first generation TKI in the upfront setting, it would be with chemotherapy, because that is where we have the evidence where it is better off, than a TKI alone. So,
but a single agent chemotherapy is not good for you. Fantastic. Dr. Amit, what is your take?
Good evening, sir. Sir, if a patient is affording an osimertinib is offered as first line TKI, then it's good enough. Other than that, if we are offering geftinib, if patient performance score is good, then why not TKI plus chemotherapy? That is also one of the optimum choice.
That is also one of the fantastic options over there. So, Dr. Shruti, how do you decide? How do you decide between the choice of treatment? Is finance the only concern? So let us say tomorrow, Dr. Vanita is my examiner, and she's asking me, patient has a lot of money, but I still want to go ahead and give EGFR, TKI, and chemotherapy. How right or how wrong are both of us? Money is not an issue. Let's just put money out of the equation. Put the science over there, Shruti. How would you want to take it?
If the money is not the issue, I don't think there is any specific reason why I would not want to choose a third generation TKI. So, yeah, so I would want to offer it to everyone, irrespective of the sites of metastasis, brain metastasis or not, but irrespective of the mutation, in fact.
Fantastic, fantastic.
Yeah, I don't think there's any other reason.
Next time you meet Dr. Vanita, both of us will wear helmets over there and meet her. Fantastic. No, it's absolutely okay. Mudassir, you have had what to do when you meet Dr. Vanita next. But what is your take on this? A new patient with EGFR mutant non-small cell lung cancer.
Sir, third generation TKI.
Third generation TKI. Order one more helmet. Fantastic. Dr. Amit Shahrawat.
Sir, third generation TKI first choice. If affordability is not an issue.
Okay, Dr. Vanita. So you're coming with
Ullas, third generation TKI. Our patient is affordable. Yes, of course. Why would you take the toxicity? Certainly, third generation TKI.
So now let me reverse the question now. Now let us see, Mudassir, I know where you're coming to. Now let us see, patient is not affordable. So now tell me, Mudassir, what would your first choice be?
Sir, okay, sir, regarding the previous question, I have one counter question to you, although I am not supposed to ask you questions.
No, it's okay. I'll pass on to Dr. Vanita. It's okay. I'm the moderator. I can do whatever I want.
In 2021, if the patient is able to afford everything, is it going to be unethical to prescribe anything other than third generation?
So I always think it is going to be, I don't think, see, do you, in Indian cricket team, is it always as that Virat Kohli will do the everything? Which is the better batsman? Is it Virat Kohli, Sachin Tendulkar and all? It depends on the patient. It depends upon the site of diseases. It depends on a lot of things. It is unethical to not even give them the option of osimertinib and the other options. So I will not say that this is the only option. There are multiple options. There are benefits of every option actually. So let's say, Mudassir, osimertinib is not available. Is not affordable. What would you do then?
Sir, I will then check the affordability for the second generation.
Okay, so second generation. So you keep the helmets on. Okay, Dr. Shruti.
Sorry, sir. The question is, when would I want to use
a 60-year-old female, osimertinib not affordable. There is no brain mets. What would you do? Mudassir will give second generation TKIs. What would you do? Okay, I seem to have lost Dr. Shruti. Dr. Amit, what would you do?
If patient performance score is good, then I will offer TKI, first generation TKI plus chemotherapy.
So you will give a TKI plus first generation. So we had aspirated 1-1. Dr. Shruti, are you back? No, she is not. So Dr. Vanita. Yeah, Dr. Shruti. Okay, Dr. Vanita. Patient, 60-year-old female, PS1, not affordable for osimertinib, no brain mets. Madam, what will you do?
A TKI combination with chemotherapy or anti-angiogenic agent.
Okay. Okay. So you don't want a second generation?
No.
So what is the point against second generation, Dr. Vanita? Let's put the counter question to you. So we'll just, Dr. Vanita, just hold on for a sec. I'll just, for the sake of this presentation, I'll say we all said about osimertinib, well tolerable, increase the OS, PFS, crosses blood-brain barrier. There are certain bad points about this, the Asian subgroup, the L858R mutation, the subset analysis, exactly what Senthil and I call as the torturing of the data and the cost. Let's just go on to the second generation. So let me say, Dr. Vanita, I have given some patient a second generation TKI. The patient has come to you for a second opinion. Tell me what wrong have I done to the patient?
You haven't done anything wrong, Ullas. You are playing the devil's advocate. Currently there are multiple options. As you said, we are spoiled for choice. They are all appropriate options. You would discuss the options with the patient and what gives you the biggest bang for your buck. So as far as I am aware, the OS data is the most robust for the TKI combinations and third generation oral TKI. So those would be my first choices, but certainly other choices are absolutely acceptable.
Okay, so this is what I actually kept over there. This is called diplomatically and politically being absolutely right. One should learn how to answer like this from Dr. Vanita. So this is exactly what I said. It was increased OS, PFS, maybe a preferential activity against L858R, but the adverse effect, the blood-brain activity not being known and cost is definitely a concern. This was the dacometinib trial. This is what I actually say. Combination of chemo and TKI. So Mudassir, why not a combination of chemo and TKI? What is your take on that?
The issue is that I want to give the patient chemo-free interval.
Chemo-free interval.
They will anyways receive chemotherapy sometime in future.
Okay, Dr. Shruti?
So what was the question, sir?
The question again is, why not chemo and TKI combo as the first line management of EGFR mutant non-small cell lung cancer?
So, sir, we cannot generalize this combination for everyone. And personally, wherever I have used this combination, of course, the data is so impressive, but we know how stringent we were while selecting these patients, fitness-wise. So whenever I use combination, I know that the patient is going to, have a very, very good tolerance, and it has never been I have never been wrong in that sense. But you would not want to combine it for a patient who is frail. So for a patient who cannot afford a third generation TKI, I would want to combine a first generation and chemotherapy, especially for the young fit patients, the poor ones.
Okay, fantastic. So we have multitude of options which are there. Dr. Vanita, you want to make a point?
Yeah, I just wanted to jump in for a second, if I may, just to correct
only Dr. Vanita, only Dr. Vanita, if you promise me that you will not torture me on with articles this thing on a Saturday night and a Sunday morning thing. And good morning to you too.
I will message you right after the panel. But Shruti, to come back to your point about how stringent we were, I would argue that actually our trial in which we had evaluated geftolimab plus chemotherapy, we were the most flexible. So we included PS0 to 2 patients, we included rare mutations, we included brain mets. Whereas if you look at the FLORA data, it was PS0 to 1, they were exceedingly stringent. So only sensitizing mutations, only exon 19 and exon L858R exon 21. So I would argue that it was not that stringent. There were patients who were PS2, which was 20% of our patients.
And actually, just to add it, even in the discussion, they said this is the real world data. These were the people who actually took the real world paper, which actually come, and really commendable effort from there. But that's it. And so we will now turn our attention to the real complicated cases. So again, just to summarize the sponsored session, if money is not an issue, osimertinib definitely with brain mets, without brain mets, whatever site of the disease, we will give osimertinib. If it is not affordable, then we have choices between second generation and TKI in combo. It again depends on, you really talk to the patient whether they want chemotherapy, they do not want chemotherapy, whether brain mets are there or not. There are a lot of things which will basically come into this. Now, this is something which was very close to my heart, and why I thought complex cases is what something I'll take. My cases, my real life cases, and I would request everybody to give an opinion. So we have a 60-year-old male who came with a history of headache, diplopia, and vomiting. MRI brain was done, which did not show any intraparenchymal mets, but they were they were diffuse leptomeningeal enhancement. The PET scan was done, which only said right lung mass. There were no mediastinal lymph node, there was no liver mets, there was no bone mets. A biopsy was done from the lung mass, which was the adenocarcinoma. This was EGFR mutant del19. A CSF was done, which was negative for malignant cells, which was done twice. A CSF ddPCR was done at that time, which was positive for del19 EGFR mutation. So, what would you do? So you have a only lung mass of 5 by 4.5 by 4.5 centimeter with a leptomeningeal mets. I totally agree, unusual, but that is what we had 2 years back, just prior to COVID. How would you say, Dr. Mudassir?
So there was no. Now we have an EGFR mutant on the PCR.
On the ddPCR in the CSF, and on a solid biopsy in the tissue.
That also should, yeah. So I think osimertinib, I will go for osimertinib.
You will go for osimertinib. Dr. Shruti?
Yes, sir, I agree with Dr. Ahmed that I would also
Fantastic.
want to start.
Dr. Amit? Fantastic. Dr. Amit?
Osimertinib, but what dose? What dose?
Okay, what dose? I did start with 80 mg OD. The patient responded dramatically well. The ECOG PS0 was in 1 month. PET CT scan showed partial response to treatment. MRI brain said leptomeningeal enhancement had significantly decreased. The same findings were there at 12 months also. I'll ask Dr. Vanita now. Dr. Vanita, would you ever consider giving local radiotherapy or surgery for this lung lesion for this patient? It's a tumor board discussion.
Yes, I think definitely. So a patient has had a remarkable response, and there is only perhaps now one site of disease, definitely. And I think we know that through multiple trials that these patients do benefit by giving them some.
But they had excluded anybody with a pleural effusion, with a peritoneal disease surface from the oligometastatic thing. So you would consider RT for this thing.
I would. And did you do that? I think you're going to tell us that in the next slide.
No. So yes, I will tell you the next slide. We did do, but the guy was not willing because it took opinion from Tata Memorial, who said no, don't to do. Okay. Dr. Mudassir, what would you do?
I think after 12 months, yes, I would offer.
Okay. Fantastic. Dr. Shruti?
Yes, sir. Sure, sir. I would also want to offer a local therapy to this patient. Yes.
Okay. Amit?
Local radiation, yes. Surgery depends.
Okay. And we do understand that this was CSF was positive for the ddPCR, but then the COVID came and it took a lot of opinions from people. They did not actually took RT. 20 months of the diagnosis. Last week, the PET CT scan is showing stable disease. MRI brain is now showing increase in the extent of leptomeningeal disease. He had one episode of query seizure, query involuntary movement. The CSF now is positive for malignant cells. Dr. Mudassir, now, what is the options of treatment? So the guy's lung lesion is stable. The leptomeningeal disease now seems to be progressing. What would you do for this patient?
So did he receive any local treatment then, sir?
No, he didn't. No, he didn't. But now the leptomeningeal disease is progressing. And he is still PS2. I'll say PS1 to 2. Yes. So your options right now are ABCP, osimertinib, Flora2, although not classical, PEMCAP, any other option. And just to think that you have a difficult position, just look at the thing over there and just, I know this will come, and that is why I put this across over there, just in case you thought your job sucked. Think of the other people who have worse jobs than you. Tell me, Dr. Mudassir, what will you do?
So we have to find something which is active in the brain as well. we do not have good data for, we do not have the data out for the osimertinib plus chemotherapy yet. We do not have, so can we consider some local therapy for brain right now?
But it is a leptomeningeal disease.
Leptomeningeal, yes, of course.
Now the CSF is positive. So you will get your tumor board. Let's take Dr. Shruti's opinion. Shruti, what would you do? I'll tell you what I did. I called up Kumar. I asked him, Sir, kya karu bata do? That's what I did. Shruti, tell me.
Sir, all the options are correct actually, depending on
what
the.
What would you do, Dr. Shruti? You have only 1 minute. What would you do?
I have very poor patients, sir. So.
Fantastic. Okay. Dr. Amit, what would you do?
I will try increased dose of osimertinib plus intrathecal methotrexate.
Okay, increased dose of osimertinib plus intrathecal methotrexate. And as usual, we go to Dr. Vanita Naroha. Dr. Vanita, kya karoon?
I guess some intrathecal therapy. There's some nice data in JTO recently about intrathecal pemetrexed.
That just came 2 days back after 2 days back after I discharged the patient. 50 mg pemetrexed.
But yeah, no, so I think you could perhaps continue osimertinib because the systemic disease is stable, but it's just that he's progressing leptomeningally. So perhaps you could plan some intrathecal therapy. I think that's what I would do.
Okay, so what I did was I called up Kumar and I asked him, and we gave him an option. I've made it osimertinib 160 mg BD, 160 mg OD. They are calling him back in 2 weeks' time, asking him to repeat the LFTs and then really see what exactly are we going to do with this.
So you see, our group also sometimes differs, no, in our decisions.
Yeah, ma'am. It is a tumor board. Absolutely okay. No, Kumar was more of a safety coverage. No, that something happens. I've spoken to him. Okay, last one. Dr. Vanita, I'll take your opinion only on this and then we'll close off. A 65-year-old female, CT4N3M0, MRI brain normal, RT opinion taken, large RT fields, unlikely to tolerate CTRT. You will give induction chemotherapy. You will give osimertinib. You will give, what will you do?
So first geriatric assessment, look for the patients.
I forgot that. She's 64.9.
Yeah, no, it's 60 and above, Ullas, you're not
59.9.
So if the patient is fit, then we see this all the time, right? We start neoadjuvant chemotherapy and reevaluate after 2 or 3 cycles because we still want to attempt to deliver any CTRT. If you can deliver CTRT, great.
Option B, neoadjuvant chemotherapy followed by reassessment. That's what you would do, Dr. EGFR 19. Dr. Shruti.
Yes, sir. I totally agree with ma'am, sir.
You totally agree with madam. Yeah. Dr. Amit.
Neoadjuvant chemo, then reassessment, depending on
Fantastic. Mudassir?
I would like to take the patient to RT if it is possible by chemotherapy, and after that.
Okay. So my take on this would be, and what I have done in a couple of patients is, I think the response rates to oral TKIs are more than what they are to chemotherapy. I would probably give just give osimertinib for 3 months, get the patient to a condition and then give CTRT after that. That's what I would do. That's what I have done it for a couple of patients. Dr. Vanita, your take on that?
No, absolutely acceptable as long as we discuss with the patient that this is at least currently off-label use, but absolutely, and that would be the right thing to do. I mean, I think eventually the data will support it.
Yeah. So that is again what I was saying, just in case you thought your job sucked, look at the person on the screen. I'm sure we are in a much more better position than this. And just to get you guys out of their misery, my time is up now. And we will go to the last slide, which basically is this. And that's what I would like to conclude by saying, if it was not for the greater variability among individual, medicine might as well as science as not an art. And thank you. Thank you all my panelists. And thank you, Dr. Vanita, for bearing with me my stupid jokes. And thank you all the audience. Thank you. Thanks, Satan.
Thank you, sir. Thank you.
Thank you, sir.
Thank you so much, sir. Thank you to all the panelists. We'll move on to the next session. This is lung cancer 2, and we'll move on to the abstracts. Our first abstract presenter is Dr. Nishita Shetty, medical oncologist from Bangalore. Over to you, ma'am.
Thank you. Good evening to all. I thank the team of Best of ASCO 2021 for giving me this opportunity. So I have the abstract from UK by Anthony Pennell et al. It was a phase 2 trial of oral vinorelbine as a second-line treatment in patients with the malignant pleural mesothelioma. Next slide. So the design was like this. The patients included were histologically confirmed mesothelioma with the ECOG of 0 to 1, and they should have received prior platinum-based therapy, and there was evidence of frank progression. So it was a 2:1 randomization in which patients were divided into active symptom control as per local practice, and the other arm was 2 doses of vinorelbine, either 60 milligram per meter square orally on day 1, 8, 15, or vinorelbine 80 milligram per meter square orally on day 1, 8, and 15. Both were a 3-weekly cycle, and along with this, active symptom control was ongoing. And evaluation was done at 6 weeks, every 6 weeks with a CT scan or until disease progression. Next slide. So the main endpoint of this study was PFS, and the secondary endpoints were overall survival. If there was any difference in response based upon the BRCA positivity, and then response rate. So coming to the the primary endpoint, that is the PFS, active symptom control and vinorelbine was definitely better than only active symptom control. The median PFS was 4.2 months with vinorelbine compared to 2.8 months with the active symptom control, with a significant p-value. Next slide. Now coming to the PFS by BRCA expression, they had done the study in both negative and positive, and they found that there was not much of a big difference compared when BRCA was taken into consideration. Now, if you see the left side, it was BRCA negative, and the right graph is BRCA positive. If you see the p-value, both the p-values were significant, and the PFS rates were also as per the primary endpoint, that is 4.4 versus 2.5 months, indicating that irrespective of BRCA, there is a benefit of addition of vinorelbine. Next slide. Coming to the important endpoint from our practice point of view, but it was a secondary endpoint for the study, it was overall survival. Overall survival was only marginally better with vinorelbine, and as expected, the p-value was not significant. Next slide. Coming to the response rates, so the response rates was as per RECIST criteria, importantly PR, stable disease, and progressive disease. So again, vinorelbine arm was better with all these rates, and progressive disease rate was also, it was higher in without the chemotherapy arm. And median duration of responses was much better with vinorelbine, around 7 months, and without vinorelbine, it was around 4 months. Next slide. So coming to the conclusion, the main endpoint, number 1, so vinorelbine met its endpoint of improved PFS. There was a 2 to 2.5 month PFS benefit with in malignant pleural mesothelioma with vinorelbine compared to only active symptom control. Number 2, BRCA positivity or negativity did not make much of a difference. The final conclusion was it is a safe and effective treatment and could be considered as a second-line option in malignant pleural mesothelioma. My take on this study is, number 1, it is a good study because it gives us one better option after platinum. We use pemetrexed carboplatin. So here we have an oral drug which could be tried. One negative thing, what I could find was they took only good PS patients. Majority, we see second line poor PS patients. So I would be happy if PS 2 and 3 were also included. Thank you.
Thank you so much, ma'am. We'll move on to the next abstract presenter. Our next presenter is Dr. Mudassir Ahmed, medical oncologist from Noida. Over to you, sir.
Good evening, everybody. So I am presenting a pooled analysis of immune-related adverse events and efficacy from phase 3 trials. Those are IM-Power 130, 132, and IM-Power 150. They were presented by Dr. Sochinsky in a recent ASCO. Next slide. And as we know that the immune-related adverse events which are caused by the off-target immune and inflammatory activity have been reported in up to 80% of the cases who are the patients who are receiving immunotherapy, and even sometimes maybe higher in those patients who are receiving combination therapy. There have been increasing evidence, which suggests that these immune-related adverse events may be related to the efficacy of these drugs. We know that atezolizumab has been approved in the first line, second line, and beyond indications in non-small cell lung cancer. And these three trials, that is the IMpower 130, 132, and 150, this is the post hoc analysis of these three trials. The IMpower 130, 132 used nab-paclitaxel carboplatin, or NAP or platinum plus pemetrexed combination plus minus atezolizumab, and IMpower 150 used the same combination plus minus bevacizumab as well. Next slide. This trial was basically to find out whether the immune-related adverse events make any difference in the two arms based on overall survival and other endpoints. So it was a post hoc analysis evaluated in association between the immune-related adverse events and the efficacy in these three trials using pooled data. The trial study design has been already shared. The grafted atezolizumab either into these background backbone chemotherapies. The treatment was continued until the loss of clinical benefit, toxicities, or progressive disease. And the trials were, when the trials were pooled, there were a total number of around 2,500 patients, and they were analyzed both in the control arm as well as in the atezolizumab arm. And on the atezolizumab arm, they were further divided into those patients who had grade 1 or 2 toxicity and grade 3 or 4 toxicity. The association between the immune-related adverse effects and the survival was explored in the analysis, and immortal bias was managed by the time-dependent Cox model, as well as the landmark analysis at different intervals in time. So this slide is showing that the overall survival by the IRA, you can see on the left side, in those patients who were in the atezolizumab arm, you can see those patients who did not have IRAs, that is the light blue line, and the dark blue line is those with IRAs, and you can clearly show that the overall survival was different between these two arms, with median OS of 13 months in the no IRA arm, and it was like 25 months in the other arm, that is with the adverse events, immune-related adverse events. And in the control arm as well, you can see the same difference, almost similar difference. You can see that 12.8 months versus 20 months. Next. As I told you that the immortal bias was taken care of by calculating these benefit of the IRAs at different time intervals. This is at month 1, month 3, month 6, and month 12. And you can see that almost at all the levels in time, the benefit was maintained in those patients which had who had IRAs rather than no IRAs. Next. So this is the overall response rate by the IRA status. You can see those patients who had IRAs had a response rate of, in the atezo arm, response rate of 61% versus 37% in those other patients. And in the control arm also, there was a difference which was maintained around 42 versus 34 months. Next. So this is the overall survival by the IRE grade. You can see that these are the three grades, that is 1 and 2, those with grade 3 and 4 IRAs in the atezo arm, and those without IRAs. And you can see the patients who had grade 1 or 2 IRAs are on the top, that is the line on the top, dark blue. The second, that is the light blue, is those without the IRAs. And those with grade 3 or 3 to 5 IRAs, they were the lowest line. And this is most probably because the treatment was at multiple times interrupted in these patients. And in later on at 12 months, you can see this line, that is the atezolizumab with grade 3, grade 5 side effects. It is almost reaching up to the other line, which is the atezolizumab with grade 1-2 IREs. Next. So these are the conclusions in the in these exploratory pooled analysis of the IMpower 130, 132, 150 trials. Patients who experienced IRAs showed longer overall survival than those without IRAs in both the atezolizumab containing arms as well as the control arms. Overall survival from the time dependent Cox model showed that atezolizumab had a HR of 0.69. Versus in the control arm, it was about 0.82. So it was significant in both the arms. Patients in the atezolizumab containing arm with grade 3 to 5 IRAs had the shortest overall survival, while those with grade 1 and 2 or no IRAs had potentially better survival. And this was potentially because of the treatment interruptions. In both the arms, the landmark analysis at 1, 3, 6, and 12 months showed longer overall survival in patients with IRAs. And the data from these analyses suggests that there's an association between the IRAs and the efficacy in patients with NSCLC. Though further support is needed of further support the use of atezolizumab combined with chemotherapy with or without bevacizumab. But I think further studies may be needed in this. Thank you.
Thank you so much, sir. We'll move on to the next abstract. Our next presenter is Dr. Mohit Sharma. He's a medical oncologist from Gurugram. Over to you, sir.
Hello, everyone. Today, I'll be presenting an abstract on first-line nivolumab plus ipilimumab plus 2 cycles of chemotherapy versus chemotherapy alone. That is 4 cycles in patients with advanced non-small cell lung cancer. This is a 2-year update from Checkmate 9 LA. So this is a randomized open label phase 3 trial and was done at 103 hospitals in 19 countries. Next slide, please. The adult patients more than 18 years with stage 4 recurrent non-small cell lung cancer with ECOG PS1 or less than 1, treatment naive, and no known sensitizing EGF or ALK alterations, they were stratified by PDL1 less than 1% or equal to or more than 1%, 6 histology, squamous versus non-squamous, and they were randomized 1:1. This was done between 24th of August 2017 and 30th of Jan 2019. Total 1,150 patients were enrolled, and out of that, 62.5%, that is total 719 patients. They were randomly assigned 1:1 to nivolumab 360 milligram every 3 weeks plus ipilimumab 1 milligram plus per kg body weight every 6 weeks plus chemo 2 cycles. Total patients were 361 in this experimental arm, or chemo alone, there were 4 cycles, and total number of patients enrolled were 358. The patients with non-squamous non-small cell lung cancer in the chemo alone arm, they would receive pemetrexed maintenance also. So as far as the chemo is concerned, in the adenocarcinoma arm, the chemotherapy was pemetrexed plus cisplatin or carboplatin, and the squamous, it was paclitaxel plus carboplatin. The primary endpoint was overall survival, and the secondary endpoints included PFS and ORR by blinded independent central review and efficacy by different PDL1 levels. And safety was exploratory. Next slide, please. So at a minimum follow-up of 24.4 months for overall survival, this database was logged on February of 18th, 2021. The patients treated with Nivo plus Ipi plus chemo, they continue to derive OS benefit versus chemo alone, with a median OS of 15.8 months versus 11 months respectively, the hazard ratio of 0.72, and the 2-year overall survival rates were 38% versus 26%. Next slide, please. As we see the PDL1 less than 1% efficacy outcomes, the overall survival in the experimental arm, that is Nivo plus EP plus chemo arm, the median OS was 17.7 months versus 9.8 months in the chemo arm. The median PFS in the experimental arm was 5.8 versus 4.9 months in the chemo arm. And the overall response rate was 31.1% in the experimental arm, whereas it was 20.2% in the chemotherapy arm. Next slide, please. In as far as PD-L1 more than or equal to 1% efficacy outcomes are concerned, the overall survival in the experimental arm was median OS was 15.8 months, and in the experimental arm it was 10.9 months. The PFS in the experimental arm was 7 months versus 5 months in the chemo arm, and the overall response rate was 42.6% versus 27.9%. The median duration of response was 11.8 months in the Nivo plus AP plus chemo, that is the experimental arm, versus 5.6 months in the chemotherapy arm. Next slide, please. The PD-L1 of more than 50% efficacy outcomes, the median overall survival in the experimental arm was 18.9 months versus 12.9 months in the chemotherapy arm. The PFS was median PFS was 7.5 months in the experimental arm versus 4.5 months in the chemotherapy arm, with the overall response rate of 50% in the experimental arm versus 31.6% in the chemotherapy arm, with a median duration of response of 26 months in the experimental arm versus 5.4 months in the chemotherapy arm. Next slide, please. So efficacy in the patients who discontinued nivolumab plus ipilimumab plus chemo due to the treatment-related adverse events, the median overall survival was still 27.5 months. There were a total number of 61 patients. The 2 years overall response rate was 54% with an ORR of 31%. And the median duration of response after discontinuation was 14.5 months. And ongoing response rate for more than 1 year after discontinuation was 56%. Next slide, please. Before summarizing, I would like to tell you about be brief about the adverse effects which were encountered.
Sir, the time is up, sir. Request you to conclude, sir.
Okay. To summarize, at 2 years, oral survival with first-line Nivo plus AP plus 2 cycles chemo was durable versus chemo 38% versus 26% in patients with advanced non-small cell lung cancer. PFS and DOR benefits were also maintained with longer follow-up. Benefit with the first-line experimental arm versus chemo was observed across key subgroups, including PD-L1 expression level, histology, and patients with CNS metastasis. No new safety signals were observed with longer follow-up. Onset of most grade 3 adverse events in the Nivo plus AP plus chemo arm was during the 2 cycles of chemo treatment. In the post-hoc analysis, the discontinuation of Nivo plus AP plus chemo due to adverse events did not have a negative impact on the long-term benefits seen in all the randomized patients. And 56% of responders who had adverse events leading to discontinuation maintained their responses for more than 1 year after treatment discontinuation. So these updated results continue to report Nivo plus AP plus 2 cycles of chemo as an efficacious first-line treatment option for patients in advanced non-small cell lung cancer. Thank you so much.
Thank you so much, sir. We'll move on to the next presenter. Our next presenter is Dr. Shruti Kate, medical oncologist from Nasik. Over to you, ma'am.
Thank you, Kashish. So the study that I am presenting is the Chrysalis study, amivantamab in combination with lazertinib for treatment of osimertinib relapsed chemotherapy naive EGFR mutant non-small cell lung cancer and potential biomarkers for response. This was presented by Joshua et al. Next slide, please. So Chrysalis study design was basically to establish the recommended phase 2 combination dose for this amivantamab and lazertinib combination. Amivantamab is an EGFR MET combined inhibitor, and lazertinib is a third generation EGFR TKI, which is very, very specific. So key eligibility criteria was metastatic, unresectable non-small cell lung cancer with measurable disease and EGFR sensitizing mutation. These patients were subjected to 2 doses of amivantamab and lazertinib, the 1050-1400 combination of amivantamab and the 700-1050 combination of amivantamab. So this was selected based on the weight of the patient, and these patients were subjected to biomarker analysis by an NGS, which was performed for all the patients on the pre-treatment tumor biopsy or the circulating DNA, which was collected prospectively. And those patients who had a tumor tissue which was remaining after NGS, IHC was performed for EGFR MET expression. Patients were then studied for the response rates. Next slide, please. So durable responses were observed with amivantamab-lazertinib combination with manageable safety. The overall response rate, as per the investigator assessed response, was around 36%. Median duration of response was 9.6 months, and around 70% of patients had a duration of response which lasted for more than 6 months. Clinical benefit rate was 64%, and median progression-free survival was 4.9 months. Next slide, please. So based on NGS, equal number of responders among patients with and without identified EGFR MET-based resistance was found. So in patients who had an EGFR MET-based resistance on NGS, ORR was 47%, while those who did not have that resistance, overall response rate was 29%. Next slide, please. And among patients who had EGFR MET expression by IHC testing, so these were around 20 patients who had sufficient biopsy after NGS testing for IHC staining, and out of these 10 were IHC positive, and overall response rate was 90% among these patients. So IHC positive patients had ORR of 90%, median duration of response was 9.7 months, clinical benefit rate was 100%, and median PFS was 12.5 months. Next slide, please. So IHC identified patients regardless of the underlying genetic resistance mechanisms. Next slide, please. So it was safely concluded that amivantamab in combination with lazertinib yielded durable responses in patients who had progressed on osimertinib as prior first-line therapy. NGS identified a subgroup of patients who were more likely to respond to EGFR MET-based resistance. However, half of the confirmed responders were not identified by NGS using these criteria. IHC suggests that high EGFR MET expression may be an alternative approach to identify potential responders. So Chrysalis, a phase 1/1b study, it will seek to validate these biomarkers prospectively in a new cohort requiring tumor biopsy at entry among post-osimertinib EGFR mutated non-small cell lung cancer patients. Thank you.
Thank you so much, ma'am. We'll move on to the panel discussion. This is the second panel discussion on lung. Our moderator is none other than Dr. Vanitha Naruna, medical oncologist from Mumbai. Her panelists are Dr. Aparna Adhar, medical geneticist and genetic counselor from Noida, Dr. Rajesh Bolam, medical oncologist from Hyderabad, Dr. Venkat Raman Radhakrishnan, medical and pediatric oncologist from Chennai, Dr. Kripa Shankar, medical oncologist from Coimbatore, Dr. M.V. Chandrakant, medical oncologist and hematologist from Kolkata. Ma'am, please note, Dr. Ashish Singh will try to join. The rest of the panelists have joined. Over to you, ma'am.
Thank you. Is my screen visible?
Yes, ma'am, your screen is visible.
Okay, thank you so much. Thanks, Vamshi and all the organizers for giving me this opportunity. So in the next 30 minutes or so, I will attempt to, one second, let me put this on. Discuss these 5 abstracts. So we'll start with discussing the oral vinorelbine and relapsed mesothelioma. I added this abstract on racial disparities in biomarker testing and clinical trial enrollment. Though this was entirely in the US population, I thought this was very relevant for our patients as well. We'll discuss the pooled analysis of immune-related adverse events, the CheckMate 9LA update, and if time permits, we'll discuss the amivantamab lazertinib abstract. So coming to the first abstract, which was a randomized phase 2 trial of oral vinorelbine and second-line relapsed pleural mesothelioma presented by Professor Dean Fennell. So this was a WIM trial, and it was a 2:1 randomization between, so all patients had to have received pemetrexed and platinum, and patients were then randomized to vinorelbine, oral vinorelbine versus observation. The primary endpoint was PFS. These were the baseline characteristics, so pretty well balanced, median age of 70. Majority were epithelioid, as we often see, and all good, good, actually not really good PS. The ECOG PS0 was only in 26.5% of patients. About a third of the patients were BRCA1 positive, and their hypothesis, I think, was that the vinorelbine acts via the BRCA1 pathway, and therefore they expected to have more responses in these patients who are BRCA1 mutated. It was a positive trial. The median PFS was prolonged. It was doubled, so 2.8 to 4.2 months. There were really not a whole lot of responses, so 1.8 to 3%. Majority was stabilization of disease, and there was no improvement in overall survival, but this was a small trial and it was not powered certainly for survival. It was well tolerated. You can see that most of the toxicities was less than 5%. The only two toxicities above 5% was neutropenia really and dyspnea. So coming to to my panelists, this was the discussant at ASCO who put up this slide, and where do we fit in oral vinorelbine in the current scenario for pleural mesothelioma? So maybe I can ask Venkat, can you start? So would you apply the results of this abstract to your practice?
Madam, I think it would be on second line or third line. I don't think so. We have oral vinorelbine available. I'm not sure if you can use the IV vinorelbine as oral. I would use it second line, third line. I would be interested to see if oral metronomic with other drugs like cyclophosphamide and etoposide can replace vinorelbine in our setting, because if the drug is not available, we'll need something else. I definitely keep it for second line if patient can't afford immunotherapy, or third line after immunotherapy if patient can afford immunotherapy.
Perfect. So Chandrakant, if your patient, so I guess the question Venkat is asking is, can we actually transpose this data and use IV vinorelbine rather than oral vinorelbine? Would you be comfortable with that?
No, ma'am. If you look into the toxicity profile, IV vinorelbine, we know is not that easy to handle. The cytopenias are quite much than what is reported in this. So I would wait for the oral vinorelbine to use. So one thing I had a comment, ma'am. We also use other chemotherapy drugs. I know they are not standard, like a weekly paclitaxel, which is well tolerated. I think if the comparator arm was physicians of choice other than best supportive care, would have been a better comparison in this trial.
I totally agree. And there was, I guess, let me ask Rajesh, what are your thoughts? So assume your patient has received pemetrexed and platinum. I guess one of my other questions is, are you adding bevacizumab in your first line with pemetrexed and platinum?
Majority of the times I use PEM and platinum measures. For few patients, I tried using bev in the first line.
Okay, and so your patient has now progressed on whatever first line you've chosen, platinum and pemetrexed plus minus bevacizumab. Your patient can afford immunotherapy. What would be your second line choice?
Immuno, ma'am. Immuno.
Okay, so what immuno?
Madam?
Which one would you use? Doesn't matter anything, Nivo, Pembro, whatever's available?
Not specifically used in any patient. But the data is more for in a non-epithelioid, we have Ipi-Nivo, and if the patient is affordable, any immuno would be fine. Pembro, I would choose more. At least dual immuno combination toxicity and quality of life issues are there. So preferably single agent.
Perfect. So, Ashish, you're not here yet. Dr. Krupashankar, any comments on this?
Yeah, ma'am. I mean, I probably would look at this trial slightly differently. I think probably it's one of those trials where it's statistically significant, but probably not clinically so. Because you're talking about an improvement in survival of close to just a month when compared to active symptom control, and not any active agent in the second line, where we know immunotherapy has become the standard of care, especially a dual IO-IO combination of Nivo plus Ipi. So if you have an affordable patient in the second line who's not been exposed to immunotherapy, I think that should be the standard of care rather than vinorelbine.
Agree. So if your patient has progressed on platinum based as well as immunotherapy, would you then consider this data?
Yeah, probably in the third line and beyond. I think then it becomes weekly taxanes again, like Chandrakant had alluded to. That's another option as well. Or again, vinorelbine. These are valid options. Post 2 lines, I think we have an unmet need. We run out of positive options. So definitely yes.
Perfect. Dr. Aparna, your take on the BRCA1 situation in this?
So while BRCA usually regulates the spindle assembly of the checkpoint inhibitors, but again, the data over here, what they showed was that it wasn't really, there was no evidence of being predictive. So I would not give much weightage to BRCA1 in these cases.
Yeah, I agree. I don't think we have ever checked it and perhaps won't. So any of the panelists now can take this. If you had ipilimumab available, what would be your choice, first line choice? Would it be Pem Platinum or would it be Ipi-Nivo? Venkat or Chandrakant?
Definitely Pem Platinum, madam. I'm not comfortable with dual immunos with the toxicity and the cost. And there is, I'm very comfortable using Pem Platinum.
Others agree, disagree? Chandrakant?
Ma'am, in non-epithelioid, why not Nivo EP? In epithelioid, I'm okay with Pem Platinum. So not that toxic. Once we start using, we can handle those IRAs if we pick them up early. So the data is good for non-epithelioid with Nivo EP. I would use that if it is feasible.
The trial included both epithelioid and non-epithelioid, no, Chandrakant?
Yes, ma'am, but the magnitude of benefit was more to, even the guidelines say that Pem Platinum in epithelioid and for non-epithelioid we must use, it's a difficult subset and we use Nivo EP. I agree, ma'am, we can use, but the benefit is more towards the non-epithelioid, ma'am. But so I won't hesitate to use a chemo-free regimen because these will be frail patients where even a Pem Platinum would be difficult to offer. In those settings, I feel Nivo EP is superior even in the toxicity profile versus chemotherapy.
Perfect. I think I agree with that. Does anybody else have any anything else, any different thoughts?
Yeah, hi, ma'am. Hi, this is Kripa here. Just a quick thought. I think on ipilimumab, especially if you look at all the other approvals for ipilimumab, we just give it for 4 cycles. But whereas in mesothelioma as well as in non-small cell lung cancer as well, we use it. I mean, it has to be continued for 2 years. So definitely that's another thought that has to be kept in mind as well. Because if you're looking at doing the combination, and if you have a patient who's responding, you'll have to continue IPU for until 2 years. You can't stop with just 4 cycles like the other approved indications. So hence, toxicity might be a concern. So that's something which we really have to wait and look for.
No, I totally agree. But I think the counter argument to that is if your patient is surviving to 2 years with metastatic mesothelioma, like that would be really a remarkable thing. So we'd have to, I guess you'd have to weigh the efficacy and toxicity. I can't say that any of us have any experience with the IO-IO combination. So probably this will just be a theoretical discussion. So I think in the interest of time, I'll wrap up this discussion. So if I can summarize the opinion of the panelists, this is a valid treatment option for our patients with relapsed mesothelioma. We aren't quite sure where to place it in the therapeutic armamentarium. The first line setting still remains pemetrexed platinum with or without bevacizumab. In the second line with affordable patients, we probably want to offer them immunotherapy. And if they aren't affordable or if they have progressed on immunotherapy, then vinorelbine is a very valid option. So to go on to the next abstract, racial disparities in biomarker testing and clinical trial enrollment in NSCLC. So this was presented by Dr. Bruno at ASCO. The authors' objectives were to investigate racial differences in biomarker testing and the use of targeted therapy and trial enrollment. And these were across the board in patients in the United States. So it was a retrospective cohort study. They went to the Flatiron database, the electronic health record database, and they obtained de-identified data. So this was actually considered not human subject data because it was de-identified data. So they did not require IRB approval. And they collected data from Jan 2017 to October 2020. And they included, so they started with 64,000 patients and they ended up with about 15,000 patients who fulfilled their inclusion-exclusion criteria, of which 10,000 were non-squamous histology. So to look at the characteristics of the study cohort, the majority were around 70 years of age, equal distribution between males and females, 65% were white, little under 10% were black, 3% were Asian, and of note, 11% of patients had not identified their race. So that is something to keep in mind because they were primarily investigating whether there were racial disparities. Also, the majority were in the community practice setting. Less than 10% were in the academic setting. In terms of payment, because this was actually will play into the discussion, about 40% of patients had private insurance, 20% had public insurance, and the remaining was unknown. Of note, between whites and blacks, the proportion of patients who had molecular mutations, so EGFR alterations as well as ALK alterations, was exactly the same. So there was no difference. So coming to the meat of the presentation, so the biomarker testing, all patients ever tested, 76% whites and 73.6% blacks. More remarkable, ever having had an NGS testing, 50%. So half of the patient whites, but 40% black, so very statistically significant. And prior to first-line therapy, less than a third of the whites and less than a quarter of blacks. Again, statistically significant, and similar numbers in the non-squamous population. Clinical trial participation was also similar. So it was double in whites. It was about 2% in blacks and double in whites. And they also found that in terms of patients who, I'll skip this. So, and if the patient had an NGS done, then that patient was much more likely to be enrolled in a clinical trial. So 4.4% of patients who had ever had an NGS were enrolled in clinical trials versus 2% who had never had an NGS done. And in terms of the factors that were significantly associated with clinical trial participation, the significant factors were having biomarker testing done before the start of therapy, ever having had an NGS at any point in time, and race. So whites significantly more likely. So I'll take this to the panel discussion. Chandrakant, your thoughts on this? In your setting, what is the uptake of biomarker testing, NGS?
So definitely, ma'am, white versus black is something like general versus private. So the economy is the one. I think the data of the economic background was confounded, and we are not able to have the exact data. Having said that, yes, there is a disparity. It's not ethnic; it's more of a socio-economic difference, is what I find, than the actual thing. So I think if the data was more complete, I would have been happier. But a very distinct sort of a data which we have seen, not just science. Yes, ma'am.
I'm going to put you on the line here. Give me a number. What percentage of your patients have a biomarker testing? So let's say EGFR, ALK, ROS. So maybe perhaps those would be the most actionable.
Yes, ma'am.
Give me a number. All patients have 30%?
85 to 90%, ma'am.
Okay. 85 to 90% would have had all three?
Yes, ma'am.
Okay. What about NGS?
NGS less than 5%, ma'am.
Okay, perfect. Let's go to Krupa.
Yeah, I'd probably agree with that, ma'am, because I think most of our patients, especially with the free coupons that we have for EGFR, ALK, and ROS testing, they're able to get that done. But only around 5 to 10% would actually be able to get a broad NGS panel done. So, yeah. 5
to 10%. And how about the regular EGFR, ALK, ROS by RT-PCR and IHC?
Yeah, that almost, I would say, more than 90 to 95% of the patients would definitely get that done, because we do have access to the free coupons that are available as well. So most of them end up getting the EGFR, ALK, and ROS one done.
Okay. Venkat, similar numbers for you, or you're different?
Yeah, madam, almost 100% undergo testing for EGFR, ALK, ROS because of the free coupons. Very rarely, very few patients, probably 1 or 2 persons would get NGS testing. But I would like to make a point here, madam. There was an interesting study, I think, in JAMA Oncology last year, which looked at the community practice between NGS testing versus testing for, targetable, druggable mutations. And they found that there was no survival difference in both the groups. So just because you went and did an NGS didn't mean that you had better survival. If you just did selective PCR testing for druggable mutations, outcomes are same. And in a country like ours in India, NGS, the validity and 2 to 3 weeks and sometimes even a month for the test to come back, and also the interpretation of the NGS, they're all too complicated. So I won't jump into NGS so soon, madam.
Your point is well taken. Let me see. Rajesh?
95% of the patients do get EGFR, ALK, ROS. 2 to 3% doesn't go to any test. 1 to 2% go for NGS.
Okay. Ashish, have you joined? Sorry, can't tell. Okay. I must say that perhaps we are, our experience is not perhaps worse than all of yours. So I don't think that 95% of our patients are undergoing EGFR ALK and ROS. Maybe around ballpark 70-75%.
That is because you have data, ma'am. So we don't have data. It's just a mind remembrance on that we are telling. We don't have data how much we are actually. The denominator is not available for us. It's only from memory we are saying. So you would be speaking from data, and that is more actually realistic.
No, I totally agree with you, and that this was my feeling as well, that we have to be doing this in all patients. But then when you go and you speak to having the data is simple, right? You get from your hospital how many patients with lung cancer came to your hospital. So if there were 1,500 patients who came, but you did only maybe 1,000 tests, so you have it right there. So that's not,
we don't remember the patients who don't return to us, ma'am. We just remember the patients who return and who do the test. So that's the denominator is really the tip of the iceberg.
Agree. Dr. Aparna, your thoughts on this, and how can we improve access as well as the turnaround time? I didn't ask any of you the turnaround time, so maybe really quick, I can go through each of you and give me the turnaround time for your for the tests in your hospital and the NGS.
We outsource it, so even the EGFR ALK takes somewhere between 2 to 3 weeks for the report to come, whereas the NGS sometimes takes even a month, so that's also outsourced.
So are you waiting then for tests, or are you starting most of your patients on chemotherapy and then changing?
We start most of our patients on chemotherapy, madam. If the PS is poor and if non-smoker female, we sometimes start empirical TKS also. Definitely.
Perfect. Dr. Aparna, your take on this abstract, and how can we improve?
Some time ago, it was just doing EGFR ALK-ROS, like in the conventional reflex method. But I think tying up with pharma companies, what we did see in the last 2 years from our lab, and because we get sample span India, is that we did see a rise in the NGS cases that were coming in, especially from second-tier cities where tissue was an issue. And this is from our lab experience, and that's because there were subsidized rates and coupons, etc. And what we saw was that NGS, the basic one, EGFR ALK, ROS, MET, and BRAF. That's all we were targeting. We were not doing any of those complicated big panels. So and the cost was down substantially. Report was given in like 10 to 12 days. So we did see an affinity towards a lot of doctors going towards NGS. But yes, there can be an issue at times when we do reflex testing where by the time EGFR is done, you don't have enough tissue to go on to ALK and ROS. So we are facing those challenges, but I am seeing a very slow trend, especially from first-tier, second-tier cities, at least from private hospitals. I do understand cost constraints are there from government hospitals, but we are starting to see a very slow shift. And I do feel that as a lab, the frequency and the demand for basic NGS, again, I'm not talking about those big complicated panels, a very small 5-gene lung-specific panel, it is increasing, and there is validity. There are good panels that are available from like Thermo Fisher, ready-made, well-validated panels from Thermo Fisher, Illumina, which reliable labs are doing. So I do see a slow trend, but it is switching more towards NGS. But I don't think we're as, I think we're doing a far better job in biomarker testing versus our US counterparts. I do feel that is there, that our patients are getting a better, better opportunities with respect to testing, for sure.
Perfect, thank you. Another question for you, a little bit out of the scope of this abstract. Dr. Rangarao has asked a question on the chat in terms of PD-L1 testing. You have thoughts about PPS, CPS platform, assay?
So we do, so the two most common platforms that we use are the Ventana SP263 and the DACO22C3. Again, with the TPS, CPS scoring, the problem comes if the lab is not properly trained and the pathologist does not understand how to call out a TPS or a CPS score. I think that's where the key issue comes about with our, with calling out these with scoring PD-L1. So for me, I do think that from a good lab, there is no issue. These are getting tied in. Again, PD-L1 only gets done when a patient can afford immunotherapy and it is an option to them. So I don't see a frequency. I don't see that many patients coming in for PD-L1 testing just because a patient cannot afford that therapy, if even, let's say, they do qualify for immunotherapy. But 22C3 seems to top the list because it is considered the companion diagnostics. In cases where 22C3 is not there, we do see SP263 also being used. But TPS, CPS scores should be done on 22C3. That's the ideal clone.
Perfect, thank you. So I think I'll wrap up this abstract. So I'll summarize what the panelists have stated is that the uptake of biomarker testing in our Indian patients appears to be good. If we are talking about basic tests of EGFR, ALK, and ROS, and perhaps MET, it appears that the majority of patients are being tested. Uptake of NGS is still exceedingly poor and looks like maybe in single digits currently. So to go to the next abstract, this was the pooled analysis of immune-related adverse events from the IMpower 130, 132, and 150 trials. I'll skip this in the interest of time. So basically, there were 3 trials studying the combination of atezo with chemotherapy, either chemo on carbo or nab-paclitaxel or PEM-carbo with or without bevacizumab. So the authors pooled this data and divided it into the atezo-containing arms versus the control arms. And in each arm, they divided it into patients who developed immune-related adverse events or non-immune-related adverse events, and similarly in the control arm. Now, this seems a bit counterintuitive as to how you would get immune-related adverse events in the control arm, but we can discuss that in the panel discussion. So the bottom line is that in the atezo-containing arms, approximately 48% of, a little about half of the patients had immune-related adverse events, while in the control arm, it was 32%. So not insignificant number. The patients who developed immune-related adverse events in general did better. So they had a better overall survival, both in the immunotherapy arm as well as in the control arm. So significantly better if they developed immune-related adverse events. Of course, the benefit was more in the atezo arms. This benefit was present at all of the time points, so at 1 month, at 3 months, at 6 months, and at a year. When they graded it according to the grade of the immune-related adverse events, the patients who had lower grades, so grade 1 or 2, did the best. So that's the dark blue line. The patients who had no immune-related adverse events were in between, and the patients who had grade 3 or grade 4 immune-related adverse events did the worst. And this again was consistent across all the time points. I'll skip this in the interest of time. So let's take this to the panel now. What are your thoughts on this? So if you had a patient who developed a grade 3, grade 4 immune-related adverse event, so does this play into your thought process, into your decision-making? Chandrakant, we'll start with you.
Yes, ma'am, definitely a greater IRAE, definitely we have seen not only in atezo, we have seen in Nivo trials also that if the grade 3, 4 adverse event is there, the PFS and overall survival is also good. So the take-home message is we must pick up these grade 3, 4 adverse events very promptly and should have a high degree of suspicion, because if we lose a patient of these grade 3 adverse event, then that is not acceptable because his oncological outcomes would be great. So the take-home message, we must pick up these grade 3, 4 and we have to handle them promptly because they will have a good oncological outcome. So I agree with this data, ma'am.
I agree with you. Venkat, your thoughts on the 32% rate of immune-related adverse events in the control arm?
Surprising, madam, in the sense that I don't know how to explain it. If anybody else can tell me.
Dr. Krupa, Rajesh, any thoughts? If not, I'll tell you. Sorry, go ahead.
I don't have any explanation. How come a chemo non-immune patient having a
immunotherapy really? Yeah, unless they all develop some autoimmune disease unrelated to cancer. It's weird, madam. I don't know.
Yeah, so this was the most popular question in the chat at ASCO as well. So Dr. Sosinski responded saying that, since they were blinded trials and our our understanding of immune-related adverse events is still, I guess, evolving. And so you have to attribute causality. So to say that this is an immune-related adverse events. And other than that, I think chemotherapy also does lead to many of these side effects. So it's difficult. I mean, so I guess the bottom line is that, when we are attributing causality and relatedness in trials, it's it's difficult when you attribute it in AEs. And I mean, if there were 30, sorry?
It's like the placebo effect where, you have responses in placebo patients as well. They're having.
Fair enough. I think in the interest of time, we'll wrap this up and go to the next way. I wanted the thoughts of the panelists on Checkmate 9LA. So this was the 2-year update from the Checkmate 9LA study. We all know the design of the trial. So patients were randomized to ipi-nivo plus 2 cycles of chemotherapy versus chemotherapy. And at 2 years, the overall survival benefit was sustained. Some important subgroup analysis. So there was more benefit in the smokers, in patients with squamous carcinoma. It appeared that older patients did not appear to have as much benefit. So 65 and over, and definitely 75 and over did not seem to have benefit. And importantly, the benefit was regardless of the PD-L1 level. So in all the PD-L1 levels, the patients seemed to benefit. We'll skip this. I think no new safety signals. And importantly, patients who discontinued ipi-nivo because of treatment-related adverse events actually did well. So this was all patients. And the dashed line was the patients who discontinued because of toxicity. And you can see that they have done well, maybe a little better, but definitely not worse. So thoughts of the panel on Checkmate 9LA. Venkat, which patient will you offer Checkmate 9LA? Is there any patient at all that you would offer this? Assuming that you had everything available and the patient who could afford it.
I wouldn't offer it, madam, because
sorry, I'm not able to hear. Did I get disconnected or did Venkat get disconnected?
Ma'am, we can hear you now.
Okay. Venkat can't hear you. Chandrakant, you want to jump in? Any patient whom you would offer this regimen to?
Oh, yes, ma'am.
I want to have 2 immune checkpoints.
I think Venkat is answering.
No. Venkat, not able to hear you.
Sorry, man. I wanted to say was that, if you could get the same result.
Ma'am, I think sir has some issues.
Venkat, terrible connection here. Sorry. I will come back to you. Chandrakant, your take?
Yes, ma'am. I cannot completely discard this study. I mean, if I give only IO, I have a fear that around 40-50% may progress on IO. So it's wise to have a chemo initially.
He wants to bring Nivo, single agent Nivo. So
Pradeep is trying to answer in between.
Sorry, I got cut. Yeah, I'll type it in the chat.
No worries. Venkat, answer. Which patient? Chandrakant is giving some sort of a diplomatic answer that he can't completely, but he's not telling me who he will give. So the next patient who walks in, will you give it? If assuming you had everything.
I won't give it because I feel the company is trying to push Nivo upfront.
Arey Venkat, the company is not pushing anything. They have done the study. Now you have to decide.
No, I will give with some other single agent IO with chemotherapy when I can get the same result. Why add 3 drugs when I can get the same thing with 2 drugs and lesser toxicity?
Yeah, no, I think the selling point is that you don't have the toxicity of chemotherapy for that long. You have the 2 chemo and then you're done. So I think that's it. But I think we have very long and mature data from pembrolizumab based combination chemotherapy. So I don't actually know where to fit this in, but it is impressive data. I mean, if you can get away with just 2 cycles and then just have immune therapy, I really don't know. Other panelists, Krupa,
yeah, ma'am. If I could just chip in here, I'd probably say I'd probably reserve this for somebody who's got a PD-L1 of less than 1%, because you always see that the responses or for the magnitude of benefit is always not that great with an IO alone in that setting. And here is one study which has shown us that irrespective of the PD-L1 expression, even in those low PD-L1 expressors or no expression at all, they still seem to have the same magnitude of benefit. So that particular category is what I would like to target with this combination of less than 1%. That's what I
totally agree. Yeah, maybe the squams, the less than 1%. I think that subgroup, maybe that might be a consideration. Agree. I think I will wrap up in the interest of time.
We have other options. Ma'am, with PD-L1 1%, we have ABCP, Atizo also in adeno, and we have Pembro chemo also. So there are so many things to opt even in a PD-L1 negative. So the only thing is to have a brief duration of chemo. I think that would be the most effective argument for this combination.
Yeah, no,
Probably
I
I
totally
just
agree. Yeah,
non-spams.
Rajesh. Yeah.
Madam, I have a question here. Pemka is kind of safe. We give it like water in our daycare. It doesn't have much toxicity. So I'm really surprised when everybody says chemo, chemo, chemo. I think it's not like they become neutropenic, get admitted febrile neutropenia. I'm just really that's my query.
No, I agree. It is relatively safe, but there is toxicity, na, Venkat. I mean, fatigue and anorexia.
Yeah, there is that.
And,
I agree.
So I get what you're saying. That what's the difference between 4 and 2 cycles? I get what you're saying. And in spirit of full disclosure, I have not figured out in my mind which is that patient demographic that I would offer this treatment to. I think the organizers are messaging me that my time is up, so we'll skip the amivantamab abstract. And I want to thank all of the panelists for a very engaged discussion. Thank you all.
Thank you so much, ma'am. Thank you to all the panelists. We'll move on to our next session. This session is sponsored by AstraZeneca. The session will be on management of ES small cell lung cancer case-based discussion. Our moderator is Dr. Rangarao, medical oncologist from New Delhi. His panelists are Dr. Sushant Mittal, medical oncologist from New Delhi, Dr. Deepak Kupaka, medical oncologist from Hyderabad, and Dr. Rajat Bajaj, medical oncologist from Noida. So please note, Dr. N.K. Warrior will not be able to join us. And I apologize, our chairperson is Dr. Shekhar Patil, who's a medical oncologist from Bangalore. Over to you, sir. Shekhar sir, can I request it on mute?
Can you hear me?
Yes, sir, we can hear you, sir.
Yeah, thanks for the opportunity. And there are a lot of advances occurring in the field of small cell lung cancer. To address this issue, we are having a case-based discussion in the management of extensive stage small cell lung cancer. And to moderate this session, we have got Colonel Rangarao, sir. And it is over to you, Dr. Rangarao, for the introducing to your panelists and for the further discussion.
Yeah, thank you very much,
you.
Dr. Shekhar. I mean, nice to see you in a Zoom meeting from Bangalore. Everything is fine. So I hope all of you are safe. So may I ask my panelists, Dr. Deepak, Dr. Sushant, and Dr. Rajat Bajaj to join us here in the thing. So I think Dr. Deepak I can see. Sushant is there?
Yes, sir. I'm here, sir.
And then Rajat Bajaj?
Hello. Yes, sir. Good evening. I'm there.
Yeah, good evening, everyone. So thank you very much so for joining us. So we'll, am I sharing, Kashish, am I sharing the slides or you're going to show me?
Sir, you'll have to share the slides, sir.
Okay, fine. So I think my slides are visible, and then so I'll pass on straight away for the things. So I'll come to the case first. I mean, there's a 62-year-old gentleman, and he has been a smoker. Currently, he smokes in the history of 30 packs per year. He presented with increasing shortness of breath, hemoptysis, weight loss, and early satiety. And then his PCP found a massive liver enlargement on the physical examination, and he had elevated ALT and the liver enzymes. The CT scan showed a left lower lobe nodule and then mediastinal adenopathy and massive hepatomegaly. He underwent a biopsy from the liver nodule because liver nodule, and then that showed a small cell lung cancer histology based on the IHC. So just the general questions to all the panelists, and anyone can pick up. Maybe I'll request Dr. Deepak. So what's your diagnostic workup for a suspected small cell lung cancer? General workup, the histopathology, and so on. I mean, can you just highlight very quickly?
I would be doing, so this patient is an extensive stage small cell lung cancer, at least on the CT scan, which I have. I would routinely do MRI brain for these patients, contrast enhanced MRI brain. and a PET CT in my practice. And on blood investigations, I will do CBP, renal function, liver function test, and LDH.
Right, and then apart from the cardiac function, that's absolutely right. Any differences of opinion in the staging? The brain MRI would everyone be doing in the small cell? So Shant and Rajat?
Yes, sir, I would be doing, sir.
So fine. So I think we skip. I think there's a total uniformity about the.
Yes, sir. I
about this, right? Thank you. So I think that's what the NCCN guidelines also says. So I don't think we'll waste much time on this. So here the brain scan shows no abnormal finding. That means he does not have the brain metastasis, and the biopsy from the liver shows a metastatic involvement, and the lung, the histology is already showing. So I think that's what we already shared. So the first choice, I mean, what would be Dr. Sushant? I mean, you can just spell out, and what would be your choice of the management in this patient?
So I would like to give platinum based regimen, and since patient is fit enough and he's not cisplatin ineligible, so I would like to give etoposide with cisplatinum, and also would like to give him 6 cycles. I usually give 6 cycles. And immunotherapy, definitely I like to counsel the patient for that, for the benefit. And if he's affording and able to take, then I'll add immunotherapy also to that.
Great. Thank
but
you.
if the patient is not fit for cisplatin, then carboplatin is also a drug of choice.
Right. I think that's a very uniform. So you said 6 cycles you will be using, and then when will you assess the patient?
So after 3 cycles.
3 cycles. So Rajat and Deepak, are they also in unanimity with the same thing, or any difference of opinion?
Yeah, I would do the same thing, sir. I would do the same.
Right. And does anyone would like to have a triple or an irinotecan in the first line instead of the etoposide and the platinum? Anyone would go for that? Or none?
Yeah. So initially there was a Japanese study which compared irinotecan platin versus etoposide platin, which was superior, where irinotecan was superior. But later the Western data say that it's not as great as etoposide and cisplatin. And with the liver functions in this patient, I would be a little worrisome in introducing any other agent other than cisplatin and etoposide or carboplatin and etoposide.
Right. Yeah. So thank you. I think these are standard things. So I think this we already now. I think Sushant was saying about the immunotherapy. So would you recommend immunotherapy to every patient, Deepak, or would you select certain patients? I mean, what would be your strategy with
No, for the entire discussion, I would presume that all patients are affordable. So in these scenarios, all patients upfront, I counsel these patients for immunotherapy with chemotherapy. So that's been my practice for the last 3 years.
And then between the, so I think that this answers the question that every patient would be there. So we have, I mean, I don't think I'll go waste time on this. And why do we use immunotherapy? I think this slide just wants to tell that, 80% of the patients receive the first line treatment. And from this, only 30 to 50% of the patients receive the second line treatment. And then less than 20% patients receive the third line treatment. So a quick question to probably Deepak and Rajat, do you see patients on second line and third line in your practice, or is it any difference in the percentages mentioned over here?
This third line, I've not had. I had one patient with third line treatment. Majority end up with first or second line treatment, sir, in my practice.
And then in case the immunotherapy is available, I mean, do you wish to use in the first line or in the second line?
So all the second line and the third line trials as such have not yielded positive results for immunotherapy. And the 2 trials which have consistently shown benefit in the first line met their primary endpoints, ETZO and Durva. So I would try to give it in the first line based on the current recommendations.
Yeah, fine. So I think there's a total unanimity. Wherever you can, the first line should consist of the immunotherapy along with the cisplatin or any platinum and etoposide. I think that's a very, very standard. And these are the NCCN guidelines which highlight the clear-cut thing. And as you just said, durvalumab and atezolizumab both are approved. And then in the doses were mentioned standard dosages. And when you give with the chemotherapy, how many cycles? Is there any change in the cycles? In the cycle, I mean, like Sushant was saying about 6, Sushant, would you change the number of cycles when you are giving the immunotherapy?
So although they mentioned that after 4 cycles, the maintenance Durva can be given, but I have been using 6 cycles and I've seen a good response. So I continue giving 6 cycles and then put them on Durva maintenance, sir.
Yeah. So, Rajat, I mean, is there any, if you have used the immunotherapy, has there been any difference in the toxicity with either of the agents or any one of them?
So are we talking about Atizo versus Durvalumab?
Yeah, anything. No, with chemo and without, with chemo and immuno versus only chemo.
Okay, so the toxicity profile, definitely if we are adding immunotherapy to a backbone of chemotherapy, we do expect the immune related adverse events that we now quite well are aware of, depending on the chronology, that is the skin toxicities followed by the hepatic toxicities, colitis, and then the pituitary dysfunction. All these things can happen between Atizo and Durvalumab. So there is data to suggest that Atizo can cause a bit more of diarrhea. There's no head-to-head comparison. Although in my practice, I have not seen too alarming sort of differences in the adverse events in any of the immunotherapies.
Right. Okay. So I think the conclusion of this particular thing is that yes, every patient should get the choice of the immunotherapy one, and then second thing is 4 to 6 cycles, depending on your practice, though the recommendation is for 4 cycles, and then followed by an assessment and maintenance immunotherapy. That's what is the standard recommendation. So I think that's very clear that we should give cisplatin or carboplatin with etoposide with any of the agents that you can get. So how to choose between both these things? Any thing? Maybe Deepak could take on this question.
So frankly, in practice, it's cost, sir. Otherwise, I feel both agents are equally good.
Equally good. So I mean, toxicity wise, there is no difference. I mean, in a patient, I think somebody was mentioning the Atizo has got a little more GI toxicity. Would you like to see if the patient has some IBS or any other kind of GI upset already? Would you like to choose that?
I just had one patient on Atizo who had diarrhea, which was immune related, and with oral medications itself that got relieved. I've not used Durva in this line, whereas for in the consolidation setting in locally advanced NSCLC, I've seen hypothyroidism, but not much of any other side effects. But for the cost constraints, I prefer using Atizo in majority of the patients.
Okay, so I mean, these are the two studies. Maybe Dr. Sushant, would you like to just go through the slide and explain some of the differences in both the trials, IMP 133?
Yes, sir. So the Durva study, Caspian study, had given the option of using cisplatin and carboplatin, either of them, which is in consensus with the real world practice what we are doing. However, with Atizo, it was only carboplatin which was taken. And also the brain mets patients were excluded in the Atizo trial, which is very point to be noted, because majority of the small cell do have brain mets as it's a sensory site. So because of these two inclusion criteria in the Caspian study, I feel Durva is a better choice, and we have a better modality, as it gives us option for using carbo or cis, and to also take care of the brain metastatic patients.
Right. Thanks. And this actually reflects the real world clinical practice, because we've been all along thinking whether to use a cisplatin or carboplatin, and which choice depends upon the practitioner who is giving the patient. So I think, and then also up to 6 cycles of chemotherapy have been given. That's another thing which we were discussing between 4 and 6. So it really reflects the real world practice, and then overall survival. So Dr. Deepak would like to comment on these two charts, comparative charts of the OS benefit.
Yeah, so in this line, at least both the PD-L1 inhibitors have shown that survival advantage to the tune of 2 months was seen. There is no further improvement by the addition of CTLA4 inhibitors to the current PD-L1 inhibitors, which was seen in the Caspian data. And there are around somewhere between 50 to 20% of the patients who do well on long-term basis. So even at 18 months, somewhere around 20% of patients in both arms are still alive and doing well. Though the PFS has shown a trend of somewhere around 4 to 6 months based on the study we choose, but consistent results have been seen, and the tail of the curve is getting plateaued at around 18 to 20%.
Yeah, fine. So both are there. I mean, except the here, I mean, if you see the Caspian study, the tail seems to be more stable than the MP trial. So one cannot say what is the reason for that, but I think that's the thing. Though I'm not sure whether that's a right way of comparing across the trials. But I think both are, you as you very rightly said, both have shown. And then though this 2 months. So when you tell the patients, I mean, what is the acceptance of benefit of 2 months of overall survival, and the PFS is just by about a month? How many patients object or accept this thing, and how have you accepted this benefit? So maybe Rajat could take on this.
Yes, sir. So, like I was listening to the other panelists also, this data which is there in both the trials, this data definitely tells us that there is an improvement in the overall survival. More realistic is the Caspian data, as everyone was pointing out. But then at the end of the day, if we are bringing finances into consideration, then we really have to delve deeper into the discussion between the doctor and the patient as to what is the cost benefit ratio that we are really looking at. So this said, also we know one thing for sure, that after a long period of time we have had a drug where there is a survival benefit that has been seen in extensive stage SCLC, which uh, by convention is known to have a bad prognosis. So definitely this is a point of discussion that has to be there. In my opinion, it should not be offered to all the patients. It should not be offered to patients who have got a poor performance status. We should select patients who are having a good PS, because ultimately we've seen that in immunotherapy trials, most of them PS matters a lot. If the PS is PS 0 or 1, only then I would offer to my patients, if of course finances are being discussed simultaneously. And the benefit has to be told to the patient upfront and in a good amount of detail. If the patient is not really worried about the cost benefit ratio, then we should go ahead and give this. Certainly there is an OS overall survival benefit, but then it is a minuscule benefit, and that part has to be discussed with the patient and the attendants.
Yeah, very well brought out. I mean, excellently, very well summed up. I think that should be the real practice. The patient should be told. So, may I ask Sushant and Deepak whether you've seen patients who have survived for longer than what has been shown in the trials? Any patients?
Yes, sir. Couple of patients I've seen who have survived longer,
So,
3 years or 4 years.
Right. I mean, because these figures are all median figures that we are talking of.
Yes, sir.
They don't, I mean, there's a range of the, survival, and some patients may still do very well. And then some of the tail enders, they may actually can go on for some time. So I think that is the candlelight, right? Thank you. I think that is a very good thing. So I think coming to the this patient coming back to the patient, he has received this cisplatin etoposide with durvalumab, and then after 4 cycles, the assessment shown that the complete resolution of the liver metastasis, and then he is on a 4-weekly durvalumab maintenance, and then he is having the scan every 3 months without any evidence of progression. So coming to, I think, so the patient has done very well. Coming to the PCI, now let's say that this patient has shown a very good response in the liver, in the lung, and there are no brain metastases. So would anyone like to have PCI, and what will be the surveillance of the brain in this patient in case you're not doing the thing? So maybe Dr. Deepak?
So at least in the durvalumab arm, where they've evaluated patients with PCI, without PCI, they've seen that durvalumab, the CNS control was very good in patients who had durvalumab. Contrary, in the atezo arm, they've told that giving PCI decreases the chance of brain metastasis. So in my practice, I would eventually give patients PCI. I'm currently doing that, but with the new data coming up with MRI on every 3-monthly basis, we can avoid PCI in a selective group of patients. In practice, I'm giving PCI for now, but down the line, probably I would try continuing on MRI surveillance for a few patients who are not keen on having whole brain radiation.
Yeah, just a side question, that when PCI is being used, and there is a new recent study showing that the hippocampal sparing PCI does prevent the various psychosomatic functional deformities.
So the recent study which evaluated PCI with the hippocampal sparing IMRT eventually showed that the primary endpoint of that study was not met. The decrease in the 5-point decrease in the score, the neurocognitive score, was not met, and they've told hippocampal sparing PCI might still not be the standard of care yet. So I think we need to wait for few other studies which will evaluate this data as we go forward.
Right. So there are some controversies about the PCI improvement in the survival. Some said yes, some said no. I think till that time we take our own calls in that using the PCI in these patients. So I think we'll be running short of time. So coming to the last question, the thoracic radiation. So if in a patient of who's responded very well, and then no brain metastasis, and then no other extra thoracic metastasis, or they have resolved. So can we resort to the thoracic RT? Rajat? Are you there, Rajat? Yeah, maybe Sushant, you can take on by the time Rajat joins.
So this question always puts me in dilemma whether giving thoracic RT to the patient who have responded very well, whether I'll be giving him esophagitis and radiation immunitis. So sometimes I do send them to radiation oncologist and take their opinion. Is the patient fit enough for the thoracic radiation? Then I do offer them. But if I feel that if the durvalumab is taking care and a patient is doing well and we are able to maintain it, then I don't offer. So it depends on case to case basis, sir.
Yeah. So the yeah, right. That's absolutely, you're right. I mean, because this has to be on a case to case basis, and there's no data of saying whether you should become. The limited data is available about the with the immunotherapy. Fine. So I think this is one of the, I think the greatest benefit of thoracic RT is limited to the patient where residual thoracic disease after systemic therapy with less than 2 metastases, and then the data is missing. So I think it's absolutely case based. When then these are the NCA guidelines which are actually reflecting what we are talking about. So that's a ESMO treatment algorithm that in a good patient you can give him the immunotherapy combination and then continue with the consolidation RT PCI when patient is doing very well. So I think that's what is it. So this patient is on the 4-weekly maintenance and he is doing very well. So a hypothetical question. So if the patient had with brain metastasis at the diagnosis, right at the diagnosis, and he was asymptomatic, what would you have done? Rajat, if you're there now.
Sir, I generally don't really bring into my head the question of symptomatic versus asymptomatic in no, I meant to say that when it is a small cell, then I generally tell myself not to think in those terms, and I generally start with brain radiation. I though can recall that I have had maybe 2 patients where I have had brain metastasis. And still have not started that, and the reason is that they were having severe pain because of their local compression. So I prefer to give them radiation to that side to improve their PS and the symptoms, and then dealt with them in a conventional way. So that has been just been one or two of instances where I have deterred from the conventional protocol. Otherwise, if it is a garden variety sort of a scenario, then even if it is asymptomatic brain metastasis, I'd go ahead with the brain RT first, followed by extracranial disease control.
You're right. I think it's a customized solution, an individualized solution. There's no one solution for this thing on a case-to-case basis, and depending on the peri-edema, number of metastasis symptoms, and the general condition of the patient, the systemic metastatic load. I think those are all the things which will determine the individual treatment things. So I think that's what the thing says. Okay, so that's an interesting question. If the brain metastases are present, is that brain metastasis? I think that's right. So yes, brain metastasis at diagnosis. Will the choice of immunotherapy vary? That's an interesting question based on the 2 trials. So we'll take that question. Rajat or Deepak?
So in practice, I think might not be big difference, but as for the protocols enrolled in the study, if it's asymptomatic brain mets, we can choose either of these agents. If it's symptomatic and treated brain metastatic the case, then I would definitely go for durvalumab as per the criteria of these studies.
Right. So I think that's very fine. I think we are now coming to the end of the discussion. I think that's what is it. So without brain metastasis and with brain metastasis, the Caspian study shows the survival benefit. I think that's you've already scored the point. So I think we will now, I think we're running short of time. I think we have finished the time. So this patient is doing fine. And then, so I think that's it. If the, this is very simple. Let me make it this as the last question. If the patient performance status is 2 or worse, do you consider immunotherapy in these patients or no? Sushant, the last question for you.
So not upfront. If after giving the chemo, the performance status improves, then I would like to consider.
Maybe
not
you
upfront.
start from a second this thing. So Rajat and Deepak, would any variations?
I'll quickly just summarize on this point. So there's very interesting study on pembrolizumab called the reaction study, where they've given 2 cycles of chemotherapy, where most small cells come with bad PS. They've improved the PS after 2 cycles, and patients responding, they've added pembrolizumab, and the study actually had an overall survival benefit again to the tune of 2 months, but the PFS was the primary endpoint which was not met in the study. So I think practically they have done it for 2 patients. After their PS improved, I introduced immunotherapy and they're doing well.
I think that's the usual practice. Thank you. I think that's a wonderful thing. So I think there are no role of biomarkers, PDL1 and TMB, nothing for driving mutations. I think we'll stop it there. So durvalumab and platinum is combination of the new standard of care in the first line extensive stage of the small cell lung cancer, and then it's well tolerated, marginal benefit, but I think we can afford and give it to the patient, those who are in good condition, affording, and then carefully telling them what exactly is the benefit. And better to use in the first line rather than keeping it as a reserve for the second line. That's with that message, I will end up here. Thank you very much for wonderful. Absolutely wonderful. Things. I really appreciate the way you have answered all the questions. So, if there are no, yes, there is some question. Let me see the chat box. I think so, right? Okay. So I think we have done, and then over to the organization. Thank you, Sushant. Thank you, Deepak, and thank you, Rajat, for your wonderful discussions.
Thank you, sir. Thank you.
Thank you so much, sir. Thank you to the panelists. So we'll move on to the next session. The next session is sponsored by Boehringer Ingelheim, and our speaker and moderator for the session is none other than Dr. P.S. Dattatreya, who's a medical oncologist from Hyderabad. Over to you, sir.
Thank you so much, Kashish, and the organizers. My dear friend Ramsi Krishna, for inviting me to be a part of Best of ASCO 2021. So just when you start thinking that all the EGFR TKIs are category 1 recommendations, but the NCCN guidelines understandably so talk about osimertinib being the preferred first-line treatment. Here and there comes data about sequencing the EGFR TKIs and trying to use the second generation EGFR TKI first, and at progression when T790M comes, then try to use osimertinib later versus using osimertinib first, and then it keeps you thinking that shall we think of using a second generation EGFR TKI first? And I am here today to discuss about a real world evidence of first line second generation EGFR TKI, afatinib or A versus osimertinib or O, the third generation EGFR TKI. But before that, next slide, we'll take the head-on-head comparison of first versus second and third generation TKIs. Next slide. So we have trials, next slide, which have compared head-to-head second and first generation EGFR TKIs, which was the Lux Lung and the Archer 1050. And both of them showed a significant PFS advantage by using a first generation EGFR TKI. When we come to the FLORA trial, the third generation EGFR TKI showed a significant advantage in PFS and OS also when compared to the first generation EGFR TKI. But we don't have, next slide, a second and the third generation EGFR TKI being compared head-on-head. But we now have, next slide, a real-world evidence which was published in ESMO Open Cancer Horizons, where they looked at first-line A versus first-line O or osimertinib. Now, this was a multi-center cohort study from Japan. Next slide. There were 15 centers. Next slide. This was a multi-center observational study from Japan, 15 centers where they looked at data of consecutive patients who went on to receive either first-line afatinib A or osimertinib O. And the primary endpoint was how long did the patient stay on the EGFR TKIs? What was the time to discontinuation of any EGFR TKI? So you could have used, for instance, first-line afatinib for say 11 months, then progression happened, and after 8 months, and then osimertinib worked for 8 months because the patient had T790M positive. Therefore, the TD, the time to discontinuation of the TKIs, would become 11 plus 8, 19 months. A patient could have got osimertinib, which worked for say 18 months as the median PFS, and then for whatever reason, as second-line treatment, the patient say went on to get the first-generation EGFR TKI gefitinib for 3 months, and therefore the time to discontinue becomes 18 plus 3, 21 months. Secondary endpoints were there like overall survival, time, TTF, PFS, and also to look at OS and deletion, 19 patients and L858R patients, and those who did not have brain metastasis. Next slide. So what's important to my next slide is to realize that patients who were next slide, L858R with osimertinib did not do that well in the FLORA trial too with regard to the OS. Next slide. So coming to the baseline features, fairly well balanced with regard to age, the adenocarcinoma subtype, and DEL19 mutation. Understandably, next slide, you had more patients who had uncommon mutations in the group who received the second generation EGFR TKI. Next slide. And you in total had around 550 patients. Brain metastasis 33 versus 26%. Next slide, come to the primary endpoint, which was time to TKI discontinuation, which was almost same or similar in the second generation versus the first generation EGFR TKI, and there was no difference statistically. Next slide. But with regard to the overall survival, now this is a population from Japan, 15 centers, and East Asian population, and with the second generation EGFR TKI, the median OS comes to 3 years or 36.2 months. In the osimertinib group, this was 25.1 months, which is pretty less. But if you look at the FLORA trial too, next slide, in the Asian patients, the Asian population, next slide, seems to be doing, next slide, the diamond, as you see, almost falls for the Asian population can compare to non-Asian populations. So therefore, the 25 months median OS with osimertinib in this particular multi-center retrospective observational cohort study was less than using the second generation EGFR TKI first. We now come to the other secondary endpoints. Next slide. TTF similar, progression-free survival similar, DEL19 hazard ratios, L858R hazard ratios was similar in patients who had brain metastasis. Understandably, I think we need to realize that osimertinib crosses the BBB much more effectively than the afatinib, and therefore the hazard ratio for PFS strongly favored osimertinib over afatinib. In those patients of L858R who did not have brain mets, and overall in those patients who did not have brain metastasis, hazard ratio of more than 1 was favoring afatinib when compared to osimertinib. So we are getting some data from this Japanese study of 550 patients where using a second generation EGFR TKI first possibly makes sense. And that brings the question, next slide, as to how is this second generation EGFR TKI different from other TKIs? Next slide. So we know that afatinib, next slide, like osimertinib, irreversibly and covalently binds to the EGFR common mutations, and also it binds, unlike osimertinib, to the uncommon mutations as well as the wild type EGFR. So this drug has pan-ERB blockade, and that might account for, next slide, the better efficacy. And the next slide, in patients of uncommon mutations. And also, when you use this second generation EGFR as first line, you possibly end up having tumor enrichment with T790M. And therefore, we are coming to a concept of enriching the tumor with T790M after using as first line a second generation EGFR TKI. Next slide. So we'll talk about tumor clonality and tumor enrichment, and how the spectrum of EGFR inhibition can help us. Next slide. So we'll talk about the EGFR clones evolving. Next slide. It's very heterogeneous in EGFR mutant non-small cell lung cancer, low mutational load. Next slide. So we have a hypothesis, next slide, that after getting exposure to the first generation EGFR TKIs, when progression happens, you end up having heterogeneous subclones, next slide, which could be T790M or minor mutations or compound mutations or other mutations. But next slide, when exposed to a second generation EGFR TKI first, because it's having a pan-ERB blockade, you prevent evolution of heterogeneous clones, and therefore you improve the PFS with the second generation TKIs, and afterwards osimertinib works on a much more homogeneous population of T790M clones only. Now that's the hypothesis after exposure to a TKI first generation versus second generation. Next slide. We have preclinical evidence of this hypothesis, next slide, in patients who, in cell lines which are BAF-bar3 cell lines, you found that you had more T790M clones which were homogeneous following treatment with a second generation EGFR TKI than a first generation EGFR TKI. So hypothesis has now a preclinical evidence, but do we have a clinical evidence? Next slide. So we do have clinical evidence again from Japan. Next slide. Again, this is a retrospective multi-center single country study where they compared the efficacy of osimertinib after having received either a first generation TKS first line or a second generation EGFR TKS first line. What they found was osimertinib, next slide, has more response rates and more disease control rates when a second generation EGFR TK is used as first line, and this was significant statistically. With regard to the median PFS, again, a difference of more than 7 months favoring the usage of a second generation EGFR TKI first. The p-value, as we know, is not that significant because of the low numbers in this study. But what this tells us, it provokes us to think that using a second generation EGFR TKI like afatinib first also makes the osimertinib as second line work better to produce more response rates, more disease control rates, and probably also improve the median PFS. Next slide. And so therefore, let's look at next slide, resistance mechanisms following first line treatment. Next slide, please. And that's different when you look at using next slide and the next slide, using a first or second generation EGFR TK as first line versus using osimertinib as first line. You end up in almost 2/3 of patients, no known target present to which you can use any drug, because you would not be having druggable targets when a third generation EGFR TK is used first. Next slide. So more often than not, when we use osimertinib as first line treatment, we almost always end up as chemotherapy as second line treatment. When you use a first or second generation EGFR TKs as first line, there is a pretty good chance you might end up using osimertinib as second line and then chemotherapy as third line. Coming to the last 2 slides of my talk, next slide. So we look at a Dutch analysis which was published in 2020 where they looked at outcomes of treatment sequences. Next slide. So as first line afatinib, next slide, on progression, 63% of them got T790M and 37% of them did not. And what happened next? Next slide. So these patients, they get as first line afatinib, on progression T790M positive as second line osimertinib, and then as third line chemotherapy till the time they go on to get best supportive care. Next slide. And the median time of treatment in T790M plus patients is 32.8 months. Now, in those patients who are T790M negative, because you can't use osimertinib as second line, therefore they go on to get chemotherapy and other combinations, the median time of treatment becomes 23.5 months. Next slide. Look at the entire population, the median time of treatment after first line second generation EGFR TKI is 29.1 months. Next slide. And the same was done when patients got as first line osimertinib. Next slide. And the median time of treatment overall became around 24.7 months. So I think this makes us think that using a second generation EGFR TKI as first line and reserving the EGFR TKI third generation osimertinib so that we have more chemo-free treatment might be an option to use in EGFR mutant non-small cell lung cancer. To summarize, next slide. So we have lack of phase 3 trials comparing first line osimertinib against first line afatinib. Second generation EGFR TKIs have covalent irreversible pan-ERB blockade, and this broad activity can be the reason for its action on preventing the generation of heterogeneous tumor clones and also act on uncommon EGFR mutations. Even the rate of T790M in various clinical trials seems to be underestimated, and therefore repeat biopsies and sensitive testings would improve detection. Lastly, lack of options following first-line osimertinib and longer chemo-free period with sequencing still keeps the first-line option after debate and under debate after having listened to this data from Japan, 15 centers, a multi-center study. So with that, I would like to invite my panelists for today, Rahul Sood from Command Hospital, Bangalore. Rahul, are you there?
Dr. Dattatreya, hi.
Hi, Rahul. Hi, nice to see you again.
Right.
Jovita Martin from SRMC, Chennai.
Hello, sir.
Hello, madam. Hello, ma'am. Yeah, and Manish Singhal, my dear friend from Delhi. Manish, are you there? Okay, so we are here. Yes,
Manish, so you'll have to unmute your mic, sir.
Manish, shall I proceed? Okay, so since we have now listened to this data which was published in the ESMO Open Journal, and now let's look at, let's start the panel discussion. I mean, like every time, just now and then, some data from the second generation EGFR keeps coming, and therefore the sequencing things continues to be under debate. Next slide, under debate. Next slide. So my question, Rahul, could you first answer? In EGFR mutant non-small cell lung cancer, in your practice, how will you choose the best first-line option for your patient? Because, next slide, you could have, as I ended my first slide, this is the NCCN guidelines here showing various options, including the fact that the preferred option is osimertinib, though all of them are category 1 recommendations. Next slide. Next slide, please. So is osimertinib the best option according to you, Rahul?
I think it is a good option, but I won't say it is the best option. So we really would like to sit and ponder over what are the other things that the patient has. Also, I think in where we have so many options, I think it is important to sequence our therapy very importantly. Start on a therapy, but keep in mind what if the patient progresses. So in majority of our cases, what we do is we start the patients on the second generation TKI, thinking that yes, the patient has another option and will probably acquire a T790M mutation, and we have a third generation TKI thereafter. So this is how we go ahead. But yes, brain metastasis is an important factor, but majority of the cases we go for a second generation TKIs.
Jovita, madam, your comments or thoughts about choosing the best first-line treatment option?
Absolutely, as Dr. Rahul had said, we will definitely bank our choice based upon number one, the mutation study that we get, and number two, financial aspects as well. So if we have a T790M mutation upfront itself, then we have no other choice. We have to go for osimertinib. But in a case where we don't have that, we have uncommon mutation and stuff like that, I think the best option will be to go ahead with a second generation TKI such as afatinib.
Thank you, ma'am. So I think what we understood is that as long as the patient has brain metastasis, the first line treatment of choice almost always becomes osimertinib. Otherwise, and a rare patient where T790M is upfront positive. Otherwise, almost always we need to deliberate upon the choices we have, and a second generation EGFR TK as first line, and then a third generation as second line, depending on whether the patient on progression as T790M or not. It continues to be a very important viable option in clinical practice. Next slide, please. Next slide. Yeah, next slide, please. So Manish, this is what we have been discussing on the next slide, please, about using osimertinib and then directly go on to chemo versus first or second generation TKS first, and then reserve osimertinib for patients who are T7 positive, versus my question to you next slide is, where do you place the TKI plus chemotherapy combination options or the TKI plus ramucirumab options in your clinical practice? Manish, are you there? Rahul, your thoughts on using a TKI plus chemotherapy option?
Yeah, so I think we usually start a patient on a chemotherapy agent while waiting for an NGS. So we start the patient on probably a PEM plus cis or PEM plus carbo combination, and in case he turns out to be EGFR positive, we add geftinib to this. But what we also do is we counsel the patient for chemotherapy and for TKI, and majority of our patients says we will wait for the NGS report and probably just take the second generation TKI if the EGFR is positive. But this is a subset. There are some subsets where we start on chemo, wait for the NGS, and if it comes positive, we keep them on, add geftinib to it. But then we have more options thereafter. We have the options of afatinib if the patient doesn't tolerate chemotherapy and doesn't respond, and we get uncommon mutations, or the patient turns out to be T790M. So we can switch over and probably give them 4 cycles and then switch over to the other one. So I think there is definitely data for chemotherapy plus first generation TKI, but I think giving that is where we use it, I think.
So I think what Rahul is trying to tell us is that the options are there. There is dynamism here. There is fluidity, and therefore you can choose multiple treatment options for your patient after understanding entire profile. Manish has joined, and I would like to ask Manish, next slide please, what is the incidence of T790M mutation positive in real world following first line TKS in your practice? The reason I ask this is because, next slide, the rate of T790M detection has been highly heterogeneous across various studies, from as low as 34% to as high as 80% from 6 studies between 2016 to 2020. I mean, as you go, so when you sometimes do repeated biopsies, you actually end up getting many patients who are on first biopsy T790M negative, becoming afterwards in the second or third biopsy T790M positive. Similarly, a liquid biopsy could be negative for T790M, and then a tissue biopsy turns out to be T790M positive. Manish, your thoughts and experience on the incidence of T790M positivity after a first generation or a second generation EGFR TKI? I thought Manish joined. Jovita madam, what are your thoughts about T790M positive? Because the range is so high, from 34% to 80%.
Yes. So the thing is, Manisha says he's unable to unmute. Anyways, I'll answer this. The thing is, when we do the test upfront, most of the times the detection rate is kind of low. So subsequently, when there is a relapse and a recurrence and we try to do it, I guess the liquid biopsy pickup rate is higher. So it definitely goes beyond 60%, and so the detection rate is high.
My another question to you was, do you feel or have you seen that when a first generation EGFR TK is used first versus a second generation EGFR TK used first, have you find more T790Ms in in first line or in a first or second generation EGFR TK?
Yes, sir. As the the literature says, the clones that developed out of the first generation TKI being used first becomes a little more heterogeneous and a little difficult to tackle. But the ones which develop right after the usage of a second generation TKI, it's kind of attenuated, it's homogeneous, I guess it behaves well. So it's easily addressable with the third generation.
And the incidence also seems higher.
Right.
So my next question would be to Rahul. Rahul, next slide. With respect to T790M testing, can you answer these three questions like the frequency of biopsy, the source of biopsy, tissue or liquid, and the site of biopsy, primary or secondary or a progressive lesion rather than a more easily accessible lesion?
So I think frequency of biopsy, we do an upfront biopsy, which is definitely there for diagnosis, and we try to do the maximum number of tests on that in NGS. Now, the source of the biopsy is usually the tissue upfront, and once the patient relapses, we try to get a tissue or progresses. Sorry, we try to get a tissue, but more or less we are unable to get a tissue second time. So then there is the place of liquid biopsy. Another place where the liquid biopsy we do is when probably the tissue is very small or scanty upfront, or once the patient progresses. The site, ideally we try to go for primary, and we are able to get the primary site, and the secondaries usually are the bone, and it's difficult to get from the bones. So primary site is the preferred site, and we are able to get in most number of cases.
Right. What about a patient who has progressive liver lesions?
Yes.
Versus a patient who has a progressive lung lesions and difficult to access. I mean, do you believe that we need to biopsy the progressive lesions because then you'll be able to pick up the T790M better? Manish has joined. I'll ask the next question to him. Rahul, please.
No, I think Dr. Manish, please, you take this
No,
question.
the next question is yeah, Manish, please.
Yeah, sorry, I somehow or the other I couldn't unmute myself on the PC. There was some problem. So
we saw that.
What Dr. Rahul said, it helps me, ask a repeat question. If it is so very difficult to rebiopsy, in his own words, he said that it's difficult to rebiopsy. Then why not use the best drug up front? We know that rebiopsy is an issue, and the standardization and the quality of a liquid biopsy, if you run through those tests within our own setups, are also not very gratifying. So with respect to this information, why not use the best drug first and not resort to a second line drug in a patient who is otherwise affording and has no other limitations of using the best or the third generation drug?
So I think Manish very rightly gave out
a third generation drug.
Yes, I understand. And in fact, your point is very well taken that when a rebiopsies at progression become an issue, and then you are not sure will you really pick up the T790M or not, that issue can be resolved permanently by using a third generation EGFR TKI like osimertinib as first line. Yeah. Excellent point. But the point was that with the sequencing thing continuing to be in debate, we always talk about these frequencies of biopsies at progression and then liquid biopsy, tissue biopsy from the primary or the progressing lesion. So I think, Manish, a very valid point you brought out here. Having said that, in your clinical practice,
don't you think there is mostly a pharma-driven debate rather than an academic debate?
So what happened was in my talk also I tried to show to you that afatinib as first line as the second generation EGFR TKI seems to be, I mean, this could be a pharma driven debate, that's fine. But having said that, there seems to be science also behind this, because we are trying to make sure that chemotherapy becomes a third line or a further treatment option, which is not the case when osimertinib is used as first line. In my practice too, I mean, like say 60% of patients go on osimertinib, but 30 to 40% of patients do still go on a second generation EGFR TKI. So afatinib has its place if finances were not a question. The reason why the remaining 40% go on the second generation EGFR is because it becomes tough to afford osimertinib as the first line treatment option.
So let me ask a question. It's a very practical case scenario. A patient who goes on to a second generation TKI like afatinib, and finally has a brain progression alone, only brain progression. Now, how do you document a T790M mutation that liquid biopsy doesn't pick up to? And how do you offer the benefit of a T790M mutation or osimertinib or third generation drug to a patient like this? And this is not a very uncommon case scenario.
That's why the third question there, is therefore about the site of the biopsy, primary or secondary, or if it's not easily accessible.
The disease is under control. The patient has only brain progression now.
Which I think does happen commonly. Rahul, your take on that?
Sorry to interrupt, sir. We are falling short of time, sir.
Okay. Rahul, your take on that, a one-word answer?
Yeah, so I think it's difficult to answer in one word, but yes, there are patients who are there on this side and on the other side. Our main aim is probably whenever the patient comes to us is to delay the chemotherapy as much as possible. And I think if we sequence our TKIs properly, that is what we can do in an EGFR positive lung cancer. Absolutely, there are patients who come with developed brain mets on afatinib, and I think in these patients we give them radiation to the brain and probably progress and continue on the TKI which is there. That is afatinib. And lastly, in case, yes, if there is no T790M on the blood or in the rebiopsy which is done, the patient does not get the osimertinib, definitely, because we go by evidence and it's an acquired mutation and we know post, so the patient goes for
My
chemotherapy.
small argument is, had this patient been affording for osimertinib, would you not feel sorry for not using osimertinib upfront?
No,
in a situation like this.
No, I'll not be sorry for this patient. It's his luck, but see, we have not achieved.
The patient had the option of using osimertinib. Patient said, I could have used osimertinib.
I'm very sorry, sir. We've given extra time for the talk.
We'll just take 3 questions quickly. Rahul, which technology is best used to identify EGFR mutations in NSCLC as first line? Is it NGS versus ARMS PCR?
I think it is NGS, which is the best.
Done.
Which is the best.
Manish, EGFR blockade, afatinib efficacy in uncommon EGFR mutations. Do you think nothing else stands in comparison to the second generation EGFR?
So far, I believe that afatinib scores above everything else, although there is upcoming data on osimertinib as well.
Right. Jovita, last question to you. Afatinib and adverse events, do you think reducing the dosage hampers the efficacy of afatinib when adverse events come?
I have in practice actually reduced the dose and it has still been quite effective. At 30 milligram as well as 20 milligram, I had a very old lady with brain metastasis. It crosses the blood-brain barrier, so it's very good. So one quick answer to Manisa, actually, if you start using the osimertinib exhausted upfront, the kind of mutations that you get eventually, like the T790, the
C797S.
Wild type and the cis type, it's going to be very notorious to treat. So the only result that we have is a 4th generation TKI, probably like the blue 945, which is in the pipeline. So we are going to really find it very struggle not getting the drugs. That's why.
My last question for tonight: toxicity leading to treatment discontinuation in your practice on a patient who is on afatinib. How many patients discontinue it? Like say 8%, 10%, 20%?
No, sir. I've never had any patients discontinuing. I think the discontinuation.
Even I didn't have any patient discontinuation.
Discontinuation.
No.
So I think that's very important take-home message, that hardly in the clinical trials to only 6 to 8% of patients had to stop the drug for an adverse event. So if you choose the dose carefully and then reduce as and when required, your patient gets the benefit of a second generation TKI minus all the adverse events if you manage them properly. Thank you so much, everybody, for being, and Manish especially for bringing out the discussion. Rahul and Jovita, you were excellent in answering all the questions and keeping the sequencing debate alive even now in EGFR mutant non-small cell lung cancer. Because I think chemo-free interval is still relevant clinical practice. Thank you so much.
Right.
Kashish, over to you.
Thank you.
Very
Bye
nice
bye.
to be with you all.
Thank you so much, sir. Before moving on to the next session, we have a message from one of our supporters. Thank you so much. We'll move on to our next session. Our next session is sponsored by Pfizer, and our speaker is none other than Dr. Amit Rautan, who's a medical oncologist from Bangalore. So, without wasting any further time, I would request Amit sir to please give his talk. Over to you, sir.
Thank you, Kashish. Good evening, everyone. I thank the organizers and I thank Pfizer for giving me this opportunity. Yeah, so my slides are visible, right?
Yes, sir.
Sure. So my topic for today is going to be addressing unmet needs in the ALK treatment landscape. So now we know ALK space forms about somewhere around 5 to 7% of our patients who in the molecular driven space of lung cancer. But ALK is something which really gives us a lot of happiness when we treat patients. We always talked about having a molecular driver is very important. And if we find a molecular driver, I think probably the best driver which we can find and which makes us most happy in clinical practice is the ALK one. After that, I think would be the ROS and then would be the EGFR, because when you see the benefit which you're getting, probably ALK is the real, one of the best molecular drivers for patients. So what happened was we know we moved in treatment in the ALK positive space using ALK TKIs. We started with first generation crizotinib. We used second generation moving from ceritinib, alectinib. Now we talk about brigatinib. And then now is the third generation era where we talk a lot about lorlatinib. What we know is as you move from first to second to third generation, you're increasing your potency, you're increasing your CNS penetration, and also you're increasing your ALK resistance coverage. This was the old data. Now for us, this data becomes really very old, which actually brought crizotinib into the space where crizotinib was better than chemotherapy in the first line setting. And then we had the ceritinib data, which said ceritinib was better than chemotherapy in the first line setting. And with this, what we started learning was if you have an ALK, start them either on crizotinib or ceritinib, and that's what practice changed to. We saw the overall survival a few years ago from the crizotinib first line study when crizotinib was compared to chemo, and we saw a hazard of 0.76, where clearly patients with crizotinib are living longer than patients who got chemotherapy first. Now there's a lot of crossover here, so in spite of that, you're seeing clearly crizotinib first line was more beneficial than chemotherapy, and this kind of proves a point of why we like this mutation. Even if you look at the chemotherapy arm, you're talking of a median OS of 4 years, and you're getting better with moving to crizotinib. So clearly, one of this group of patients who do really well in long-term practice. A few years ago, we saw the alectinib data when Alex was published, and first-line alectinib versus crizotinib, clearly alectinib beat crizotinib. We saw a median PFS going from 10.9 months to 34 months with a hazard of 0.43 by the investigator assessment. And it was about somewhere around 26, 27 months when we talked about the blinded independent committee review. But clearly, alectinib was much better than crizotinib. And with this data, if patients could afford it, most patients would receive first-line alectinib rather than first-line crizotinib. Last year was the 5-year overall survival data from Alex. And now we see that if you had patients on crizotinib, your median survival is somewhere around 6 years now. You're talking of 57 months, and it was not reached, though all the events have not happened in this, so it's not mature data, but you're clearly seeing a hazard of 0.67, where alectinib is beating crizotinib, and that's why alectinib became one of the standard first-line options to go to in many of your patients. So what happens to patients when you receive first-line therapy and they move to second-line therapy? Now, when we talked about crizotinib as our first-line therapy, what we saw that we could always move to a second-generation TKI. So when they move from a first generation, they progress, you can directly go to a second generation TKI. And you have data saying that if you use alectinib, you got a PFS about 5.4 months. Alectinib as second line gave us a PFS about 8.9 months. Not that great as what we see as a first line data set, but it was about somewhere around this time of 8.9 months. And brigatinib was better than alectinib. We had 9.2 months at the lower dose, but when you went up to the 180 mg, you had 12.9 months with brigatinib. So clearly telling us after first line progression, one could go to a second line option directly. But it's important to understand why do patients progress and how they progress and how we can address it. And what we are now understanding is if patients are treated with ALK inhibitors, they can develop progression due to either mutations which are happening, and these are mutations happening which are ALK-related mutations, or it could be ALK-related, but it could be a copy number gain. So we say about 35% of patients would have an ALK mutation, about 8 to 10% of patients would have an ALK copy number gain, and that could be leading to the resistance phenomena. Alternately, it could be an alternate oncogene pathway which is becoming activated apart from the ALK. And studies have shown it could be ALK with KRAS, it could be ALK with EGFR, it could be ALK with other unknown pathways. But what is important is we are understanding that these pathways are very important, and these pathways we will come to know only if we test patients. And the only way of testing for this is doing NGS testing to understand what mutations are driving resistance. If you see the EGFR space, it's very, in terms of resistance, it's very straightforward. You know, we talk about T790M if we talk about giving first line EGFR or second line EGFR TKI, and we talk about C797S when we are talking of maybe when you're using osimertinib first line. But in the ALK space, the resistant mutations are very, very complex. There's a very broad spectrum of mutations, and there could be a whole list of mutations which we are seeing. Now, what we're learning, these are the group of mutations. We have been hearing about this for the last few years. What we learn is if we give our patients first generation ALK inhibitor like crizotinib, the chance of developing a ALK mutation, resistant mutation and progression is about 25%. But as you move through a second generation space, the chance of developing an ALK resistant mutation is much higher, goes up to the tune of almost 50 to 60 to even sometimes 70%. And the G1202R is one of the most dominating mutations which comes up in many patients. And we see that it can start off with in second generation TKI treated patients from 25% to almost going up to almost 45 to 50%. Now, this is where we come into moving to a third generation ALK TKI, and lorlatinib was designed looking at improving the mechanism of action. And it was designed in such a way that the crizotinib was shaped, it had a crown on top of the crizotinib, if you see the structure. And it was designed to have better CNS penetration, but it also binds with a high affinity and has effect in ALK resistant mutation patients. Now, if you look at all types of mutations and you look at all the drugs, crizotinib doesn't work in many mutations. Ceritinib does work in some mutations, but doesn't work in the G1202R. Alectinib again works in many, but it doesn't work in G1202R. Brigatinib doesn't work in G1202R mutation. Lorlatinib has a very broad spectrum of actions against all ALK mutations, and it works in all the ALK mutations if you look at it as single mutations, including the G1202R. Now, this was the ALK trial which was taken up, phase 1, phase 2, looking at 100 mg of lorlatinib in the space of patients who had progressed, and it had multiple cohorts. Now, if you look at the cohorts of patients who received prior crizotinib as first-line therapy, and then they progressed, they may have got chemo, may not have got chemo, and then they got lorlatinib, we saw a response rate of about 72%, and the PFS was about 11.1 months. But if you had patients who received a second-generation ALK TKI, and then they progressed, the response rate was about 42%, and the median PFS was about 5.5 months. Another important part is the intracranial response. If you had received crizotinib first and progressed, and then you got lorlatinib, you have a 70% intracranial response. The duration of response was already not reached. So it was this is a group which was really benefiting very well. Now, even in patients who had second generation ALK TKI and then they progressed, they had a response rate in the intracranial space of about 46%. If you looked at lorlatinib at progression of more than 2 prior ALK TKIs, so most of these patients would have got first generation ALK TKI and then a second generation ALK TKI, and then they progressed. If you look at the 111 patients who were treated in this cohort, there was an overall response rate of 43%, a duration of response of 9.9 months, and median PFS of 6.9 months, clearly telling us that the drug does work and it does have a penetration into the brain. Yes, the PFS is about 6.9 months, but again, it's a space where you have actually exhausted 2 lines of ALK TKIs, and some of these patients had already received chemotherapy also. So clearly it's a drug which is working and also penetrating into the brain. There's also data to say that when patients progress, if you looked at whether they had an ALK mutation or not, patients who have an ALK mutation have a much higher response. You talk of responses of about 60% with ALK mutations versus 26% without ALK mutations. And also the PFS was 5.4 months without an ALK mutation versus 11 months with patients who had an ALK mutation. So clearly in patients who develop an ALK resistant mutation, lorlatinib is a drug which is giving us better response and better PFS. But lorlatinib also eventually does become resistant, and this is how the data is turning out now. There are compound mutations happening, and this is having, they could be double mutations, triple mutations, and this is what is leading to resistance to lorlatinib. And this is how studies in the future are looking at how further resistant mechanisms develop. So compound mutations are what is causing most resistance to lorlatinib. Now moving on to response to toxicity. Now, learning of lorlatinib has always been a different learning experience. It is something to do with a different drug, and the side effect profiles has to be something that we had to little bit learn in clinical practice. One of the most important side effects has been increase in the cholesterol level and increase in the triglyceride level. Increase in cholesterol has been seen in more than 83% of patients with grade 3 in 14% of patients. Hypertriglyceridemia was seen in 66% of patients, and about 13% had grade 3 side effects. Other side effects unique to lorlatinib, edema in about 44% of patients, and some cognitive disturbance in about 23% of patients. Weight gain also is something unique to lorlatinib. Now, hyperlipidemia is something that we see so commonly in lorlatinib. We've had occasional patients who did not develop hyperlipidemia. Almost everyone developed increase in the lipid after treating with lorlatinib. And it happens very rapidly. Even in 2 to 4 weeks, we see the lipid increasing. And yes, we have to put these patients on statins using something like rosuvastatin or newer statins. But sometimes it goes so high that one needs assistance from our physician colleagues to help us in using drugs to reduce the lipids. So this is something we need to learn when we use lorlatinib in clinical practice. Another side effect unique to lorlatinib has been the CNS side effects. And these can be very variable and very vague. You may have sometimes some cognitive disturbances, some amnesia, some memory impairment. Sometimes there will be just slowing of the patient, some slow speech disorders, or patients sometimes just have irritability and depression. And this is again something unique to when we use lorlatinib. Now, basically, it's something that we need to counsel our patients and their families before we start lorlatinib. We need to tell them there's a 25% chance that this can happen. It may not be a serious problem, but it needs to be watched for. But yes, if it is becoming a serious problem, you need to stop the lorlatinib and discontinue it. So this is something, if you don't talk to your patients first before putting them on it, it may come as a sudden surprise to the families. And especially if the patient suddenly becomes very, very disturbed cognitively, it will come back to us that there's something happened because of the drug you gave. So important toxicity to understand and to how to manage it in our patients. Weight gain has been seen in about 20% of patients. Yes, this is something, again, you prepare your patient for it. It may happen, and you need to teach them how to do dietary changes. Edema is seen in about 50% of patients, and this is something that can be very disturbing to your patients. We have seen patients who had so much edema that they had trouble saying that suddenly they gained weight, they had peripheral edema, they were not able to do all the exercises they were doing, they were not able to do the yoga they were doing. And this is something that needs to be watched about, talking to them about how to do and manage edema. And this is managed using, sometimes if it's severe, by diuretics, other times by using compressive stockings and lifestyle maneuvers. This is one of our patients, a 51-year-old non-smoker. He was diagnosed to have adenocarcinoma lung with hilar nodes, bone metastasis in September 2017. He was found to have an ALK. I remember this as my first patient on a first-line alectinib, because that's the time when Alex was approved, and we started the patient on alectinib. He tolerated it really well. He did well for 2 years. But in August 2019, he had increase in lung lesions and one of the nodes. Now, we got a we got somewhere around 2 years on alectinib. I was hoping for somewhere about 30 months and above, and that's what I used to talk to my patients. But we know realistically it's 2 to 3 years, and that's where when patients would progress to alectinib. We did a rebiopsy and we did an NGS testing. My plan was just to give him SBRT to the lung and to the node and continue alectinib, and that's the decision I told him. And we sent the NGS. Now in the NGS, we found a G1202R mutation. Now this is resistant to alectinib also, and lorlatinib is only sensitive drug in this mutation available for use. So we did the SBRT to lung and lymph node. We did talk to the patient that there is a chance that we could still continue alectinib and watch the patient closely, but there is always a feeling that because we have a G1202, the drug may stop working. But we had lorlatinib that time, and so this patient just got on to lorlatinib from September 2019. He's one of the patients who tolerated really well. He had a very good response. When the next time when we did a PET, we hardly saw any disease, and he continues to do well on May 2021. Now, yes, he is one of the patients who had very less side effects, but we have had the other spectrum where one of the patients had all the side effects you could name. He had hypercholesterolemia immediately, he had edema, he had weight gain, and he also had some cognitive disturbance in terms of depression and slowing. So this is something that you can get lucky with patients with no side effects, but you can sometimes have patients who can have a whole list of side effects. So that's something we need to watch our patients, counsel our patients, talk to them, explain about the different side effects from what we have been using till now, and eventually treat them and take them forward. So how do we talk about second line therapy? In that space, we always say our second line therapy depends on our first line therapy. We say, if you use crizotinib, then you could use ceritinib, you could go to brigatinib, you could go to alectinib, and you can also go to lorlatinib, depending on what sequencing you're thinking of and how you want to take care of your patients. After first line crizotinib, do we need to do ALK resistant mutation testing with NGS? Again, it is very doubtful. Though we say, yes, 20% patients can develop a resistant mutation, but again, that space, 80% will not develop it. We will probably not do it for everyone, though yes, if we have facilities and our patients are agreeable, we could do a tissue NGS or even a blood-based NGS and look for those mutations. But after progression of a second, if you start a patient with second generation TKI, like ceritinib, and then they progress, these are patients who can have a ALK mutation developing, and there's really limited options in such patients. You look for lorlatinib as one of the options, though you could look for a mutation and choose your drug better. If alectinib progresses, again, you could look for a mutation. Now, there are different ways of looking at it. Some people would say, we just try lorlatinib blindly. Anyway, that's the only drug you have available, and that's perfectly correct. But if you really want to look at it scientifically, you could actually do a biopsy or an NGS and find out what is driving mutations. So using second line therapy really depends on how your first line therapy what has been used in practice. But now the first line space is changing, and it's changing very rapidly. And this is what happens, by the time you get to using a drug in the second line space or a later line space, the first line data comes up so rapidly, we have to again adjust and start debating what is the best drug to use upfront. Now, brigatinib was seen versus crizotinib in the ALTA-1 trial. We saw this a couple of years back, where clearly you had a PFS improvement. Now, with a hazard of 0.49, crizotinib gave 9.8 months as usual, and brigatinib, it was not reached for the hazards of 0.49. Clearly, brigatinib was better than crizotinib. And from the last year, what we have been listening to and hearing is the CROWN study. Now, CROWN study is looking at lorlatinib first line in comparison to crizotinib as first line. Now, CROWN, even the name of the trial, CROWN, is designed actually because of the shape of lorlatinib. If you see I told you, over crizotinib, they had a structure, a ring on top, which is the crown of, and with that they made the structure in such a way that it is a different drug, and that's why they named the trial also a CROWN study. We saw the data, and why we were excited about it was, if you saw the PFS by blinded independent committee review, you had a PFS of 9.3 months in crizotinib, bang on what we are having with all the trials which we do, and it was not reached with lorlatinib, though the follow-up is short. The hazards are 0.28. Which is remarkably good. You talked of always hazards of 0.45, 0.43, but here you're talking of hazards of 0.43, 0.28, which is very, very significantly better. Now, how this will pan out in the long run, we need longer follow-up, but clearly it's a very exciting drug in the first-line setting. The second reason why we're very excited with the CROWN data, if you look at the intracranial time to progression, you can't really believe this kind of a hazard. You're seeing 16.6 months with crizotinib, and you're seeing lorlatinib. That curve is right on flat on top, and the hazard is 0.07. You never see a hazard like that. It's actually below 0.1. You're talking of 0.07 hazards, clearly telling us that lorlatinib is going in the brain and preventing brain metastasis. So clearly a very effective drug, but again, we need longer term follow-up. So CROWN is something that everyone's looking at very, very excitedly. Everyone's watching the space at longer follow-up, what would happen, but clearly it is showing very good efficacy. The issue for us always is, we know for us, first line space is no longer crizotinib. Alectinib kind of takes up the first line space. We don't know the comparison of a third generation versus a second generation. But of course, if you do cross-trial comparisons, you keep seeing the hazards, you keep looking at numbers, you get excited. So this is something all of us will look for in future to understand how this space will evolve. So this is where we are at present. First line ALK TKIs, we could use any one of them. If you look at, so crizotinib now first line is hardly used except in patients who can't afford a second generation drug. But yes, in practice, because patients can't afford it, in reality, many of us still use first generation TKI. But when they progress, then you talk about going on to a second generation ALK TKI. And then when they progress, you talk about looking at third generation ALK TKIs. We do talk about looking at resistant mutations. Yes, much more in patients who progress on a second generation ALK TKI, especially G1202, which is resistant to most of the drugs, and choosing therapy according to resistance. Now, if you are moving on to second generation ALK TKIs first line, especially if alectinib, brigatinib becomes first line, then your second line space is going to be very different, and probably only lorlatinib will come in that space, or it will be chemotherapy after that. And with the CROWN data coming up, if lorlatinib becomes a very strong first-line drug, there's always that question, what will be the next line of therapy? Is it going to be some form of chemotherapy? Is it going to be combination therapy? Or is it going to be the newer ALK drugs which are being further looked at in terms of various combination regimes? But the best thing, and I think the most positive thing, is we are doing a lot for the ALK-positive lung cancer patients. Their quality of life is getting excellent. You're delaying their brain metastasis. You're improving their survival, and survival is now getting into many, many years. So these are the days when an ALK-positive lung cancer gets into your OPD, you can confidently start telling them about survivals more than 5 years and 6 years, and you start talking to them in that tone, which was something you'd never do in lung cancer before. And that's why the space is really very exciting. So with this, I would like to thank the organizers and thank Pfizer again. Thank you very much.
Thank you so much, sir. Before we move on to the next session, thank you so much, sir. We'll move on to the next session now. The next session is Looking to the Future, and our speaker is none other than Dr. M. Vamshi Krishna, who's a medical oncologist from Hyderabad. Over to you, sir.
Good evening, everyone, and thank you, Kashish, for calling me here. So I'll be talking about looking to the future, as this iconic movie says. Lung cancer has become one part where we actually need look at the future, and we can actually look at the future with a lot of confidence and with a lot of hope. The amount of changes that have happened in lung cancer over the past decade have been truly amazing in the annals of oncology. Next slide, please. So when I am talking about the future, what are the things that I would look forward to, especially based on the present ASCO? The first component is, of course, the neoadjuvant therapy and the adjuvant therapy. Next slide, please. In these, as in everywhere else, it is immunotherapy that is making our body work smarter. And really, the future is going to be for immunotherapy for a non-mutation driven lung cancer, both in terms of adjuvant and in terms of neoadjuvant. When we look at the Pacific data, we saw this year the 5-year survival with consolidation durvalumab has come in. And again, numbers are quite impressive. You're having 47% overall survival with a stage 3 NSCLC, which was pretty much unheard of. As we can see in the trial, the placebo is only 28%. So that's giving you a clear overall survival advantage with immunotherapy. Next slide. Now, along with that, we also have a resectable stage 1B and 3A, where the results of the Checkmate 816 were presented this year. And it shows that there is a PAT-CR advantage with neoadjuvant, nivolumab, and platinum. So again, not as much probably a PAT-CR as we say in, say, a breast cancer, but still very impressive numbers, and we are going to start seeing better and better as the time goes by. Next slide. Now, the IMPOWERS 010 was discussed in some detail by Dr. Ullas today. So this was a phase 3 trial of adjuvant atezo, and again, we can quibble about the PD-L1 0%, we can quibble about the intent to treat or a stage 1B, but at least PD-L1 positive, we are going to get some benefit with atezolizumab. This is not just with atezo, it can probably happen even with further other treatments and other immunotherapies. Next slide, please. So let's come to metastatic non-small cell lung cancer. Next slide. Now, this is an area which has been biomarker driven. That's the present, that will be the future, and it will come in newer avatars as well. What do I mean by the newer avatars? We are by and large trying to shift to two things. Number one, trying to go for a ctDNA based prediction, trying to look for mutations on the ctDNA as opposed to a tissue based treatment. Secondly, probably more importantly, we are actually going to start monitoring the result of our treatment, either going by escalation or by de-escalation using the ctDNA. We have already seen there are trials with EGFR levels where you look at the EGFR mutation and see whether you are able to detect the mutation on ctDNA. This can give you not only an early marker of a relapse, it can also help to decide whether to increase our treatment or not. A simple example could be chemotherapy, where you give it for a while, then you decide to start increasing your chemotherapy again after a gap whenever your ctDNA values start rising. This is just an idea of what we are looking forward to, but I think the story of biomarkers is a huge unexplored opportunity for lung cancer right now. And in the future, as we go ahead, we are going to be treating our patients based on these biomarkers. Next slide. When we talk of EGFR mutant, we have already seen multiple studies looking at progression after the first line treatment. And this ASCO, we had two trials, the Chrysalis phase 1, which showed amivantamab and lazertinib, and also the phase 1 study of patrimumab deruxtecan with EGFR mutated NSCLC. Again, EGFR has proven to be one of the most targetable lung cancers, and going ahead, we are going to see further treatment and attempts to just keep on targeting the EGFR over time. Next slide. Along with this, we also had this time a presentation of a newer first generation, a newer TKI that is known as omololertinib. Now, the idea is this would probably have a slightly different mechanism of action as compared to osimertinib. It would actually have a higher selectivity over wild type EGFR, and this study showed that there was an improvement. So again, we are looking at not just the second, third line, but even in the first line, probably some difference in the medication as well. Next slide. Exon 20 has been an unmet need for a while, but now amivantamab is the EGFR MET bispecific antibody. We are having the Chrysalis, which showed some benefit, and also this study showed us that overall response rates were very good in exon 20. So exon 20 is one more where I foresee in the next 2 years, we are going to start getting drugs. It's a matter of interest that there are quite a few trials which have started in India, and hopefully in the next few years, we are going to see these patients being recruited in trials from India as well. Next slide. So what about HER2/neu? Again, we are going to be seeing more. The Destiny Lung 1 showed that trastuzumab deruxtecan had benefit in this group, and we are now going to look ahead for the other Destiny Lung 02 and 03 studies. Again, in the next 2-3 years, it's not a short time, but I think the future really belongs to targeting, and HER2 target is definitely one which I'm interested in. The results with typical conventional chemotherapy is frankly quite disappointing. Next slide. What about other targets? So you have the KRAS codebreak study, which was presented this time. Sotorasib in pre-treated KRAS. Unfortunately, only G12C is what is being targeted. We do not have targets for the other KRAS drugs, which are in the pipeline. So this is something interesting. Next slide. We do have data about the RET inhibitors. Selpercatinib, we know it works. by and large, this ASCO showed us a novel RET inhibitor. And again, though the numbers are small, as we saw in the previous lecture by Dr. Amit, even ALK is small in number, yet you have quite a few drugs, and I think RET is slowly heading that way as well. MET exon 14, of course, there. We are looking at newer targets, and I think the targetable space is only going to expand over the next couple of years. Next slide. Immunotherapy, lots of data. This time we had the 9LA, and frankly, we are in a position of luxury with either just chemo or chemo with Nivo-IP, only Nivo-IP, or Pembro with the different chemos combinations, all of which are showing us much better benefit as compared to chemo alone. So immunotherapy is well and truly there in the first line. I think that is an inescapable conclusion from all the trials that we have been discussing. Next slide. So what do I see in the future? It's probably going to be a combo meal. We are not just going to go with one drug alone. We are going to go with an IO, different IO chemo. We are going to use chemo TKI, use TKI plus TKI, use IO NACT in different combinations. So really, these combinations are going to be the next 2 years what we'll decide. And 10 years back in the ASCO, we were probably talking of Pembro or Pemetrexed. So even I talked Pembro when I mean Pemetrexed. So we were talking Pemetrexed and platinum versus discussion. I think those are things that we have kind of settled on. We are just going to go ahead with more personalized therapy and more combination therapy. Next slide. So for me, looking to the future is a bright. It is more headache for us because we need to learn names of a lot more drugs, and we need to know the names of a lot more. Partly, lung cancer has a bright future ahead. So thank you, and over to the organizers again.
Thank you so much, sir. So we move on to our next session. Our next session is sponsored by Eli Lilly. Our moderator for the session is Dr. M.V. Chandrakant, medical oncologist and hematologist from Kolkata. And our panelist is Dr. Dattatreya, medical oncologist from Hyderabad. Over to you, sir.
Thanks, Kashish. Okay. The slides are shared already?
Yes, sir. I hope it's visible, sir.
Yeah, so I will keep saying next.
Sure, sir.
Okay. So I know we are running late and Kashish will be keeping up the time. So Dr. Satya is there. Dr. Satya, hi. Thanks for having me here. We will discuss. So we have had an extensive discussion, and Dr. Vamshi very well put regarding the combo immuno, and Dr. Amit also discussed so well on ALK positives and delve deep into it. So let us be going on to this combination where we can place this relay regimen in our clinical practice. Okay, next slide. Next slide. So these are my disclaimers. Next slide. These are my disclosures. Next slide. Next slide. So we are sort of having a very short discussion instead of having multiple panels in this short time. So let us have one-to-one discussion. I'll be presenting a case. The relay regimen has come recently and we are using in practice. I will go through a case. Okay, next slide. So this is the patient which presented to me around
Kashish, you can mute everyone.
Yes, sir. Sorry.
Yeah. So we had a 46-year-old gentleman who was diabetic on oral medications. He was a never smoker. He presented in February 2021 with the symptoms of cough expectoration for 2 months, hoarseness of voice for 1 month, and reduced appetite. Next slide. So on examination, he was well preserved with a good performance status. There was no lymphadenopathy. Left side breath sounds were reduced. Otherwise, other examination was unremarkable. Next. So his all other parameters were fine except a bit of raised alkaline phosphatase, and fasting sugar was 162, and urine glucose was 1 plus, and albumin was trace. And his echo was fine with a good left ventricular ejection fraction. Next slide. So because he had hoarseness as a presentation, he did undergo a bronchoscopy. In the bronchoscopy, in the left main bronchus, he was found to have a polypoid tumor that was causing obstruction, and it was highly suspicious for malignancy, and a biopsy was done. Next slide. So for the staging purpose, we did a PET CT that showed a 5-centimeter mass in the left main bronchus, bilateral puroparenchymal nodules, mediastinal lymphadenopathy, supraclavicular lymphadenopathy, left adrenal mets, and liver mets. So quite a heavy disease burden is what I can say. Next slide. So the biopsy, the bronchoscopic biopsy was a moderately differential adenocarcinoma. The IHC was positive for TTF1, and it was a primary lung origin. He did have a 30% PDL1 positivity. However, the EGFR luckily came out to be exon 21 mutation, and we do it by PCR, and ALK by IHC, ROS, and MET by FISH were negative. The baseline MRI was unremarkable. Next slide. Okay, so Dr. Satya, so a lot of discussion on NGS and PCR. So what do you do in your practice? Is the tissue an issue even in your practice? How do you pick up?
I think all of us now have decided that NGS is the way forward. We need to do broad molecular profiling for all our patients of non-small cell lung cancer so that we don't miss a chance to treat a druggable target. Having said that, there are a few patients who, despite the cost having come down substantially, still can't afford these tests. And in that case, the assistance from various companies like MedGenome through the pharma companies does come in as a boon. And there I send the block for individual testing for EGFR, ALK, ROS1, and PDL1, including BRAF. I think all these 5 are right now covered and run at an ultra low cost of say 4 or 5,000 at the most, rather than 35,000 individually. So NGS is the way forward.
Correct.
Otherwise, whenever assistance is required, we check EGFR, ALK, ROS1, and PDL1 and BRAF individually.
So that's very perfectly put, sir. Just to add add more points to it. So in PCR and all others, we are looking into the known mutations in the hot spots. So with the NGS, is it that you are just looking for rarer mutations, or is there a higher sensitivity of picking up common mutations? So is it just we are picking more rarer ones, or we are able to be more sensitively picking up more commoner ones? So what do you feel? Or we have both the advantages?
I think you rightly summed it up. We have both the advantages. In fact, I myself, as in my practice, where conventional tests have not picked up the EGFR mutations, but when an NGS was done by these aphotic patients, were able to find out EGFR mutations, be it exon 19 deletions or exon 21 L858 or point mutations. The delta might be less, but
correct.
You can actually pick up more patients who may benefit from by identifying a druggable target.
So very correct, sir. Instead of looking into the hot spots with PCR, definitely even missing out one EGFR mutant patient, it's not acceptable, because we have such wonderful drugs which we'll be discussing later. So the tissue turnaround time, of course, the cost has also come down. I think NGS should be the way to go whenever feasible. Okay, fine. Next slide. So this is the EGFR mutation we had in the PCR. So in the PCR, you can see that the exon 21 has shown L858R. And if you look into the type of mutations they picked up in PCR, so we have exon 18 G719X, we have exon 20 T790M and S768I. Uh, Quite good number of mutations have been picked up in PCR. So, Dr. Satya, what do you think? This is a reasonably good way of doing PCR. What do you say?
Absolutely. This is a very good report, no doubt about that. But I completely concur with you.
Correct. So it's very good. So even when you do a PCR, we should not miss out doing only the sensitive mutation. We must also look into uncommon mutations that has been reflected in this particular report. Okay, next slide. Okay, so well, the most hot topic is we know all EGFR mutations are not the same. So we have common mutations, uncommon mutations, sensitive, resistant, and so on. So Dr. Satya, you can actually explain us what is the difference between these exon 19 and exon 21. Both of them are being called sensitive driving EGFR mutations.
So across all the trials, 90% of mutations in the EGFR turn out to be either the exon 19 deletions or the exon 21 mutations. Usually in exon 19 you find deletions, in exon 21 you find point mutations, the most common being the L858R. And across all trials, deletion 19 is even more common, accounting for 55 to 60% of them, of the common mutations, and the remaining 35 to 40% or 40-45% is the L858R point mutations. More than that, we are recently realizing that deletion 19, exon 19 deletions possibly are having a better prognosis and a better response to treatments than the L858R. For instance, you look at the FLORA data also. When you look at the subset in L858R, in fact, the diamond actually is sitting on the unity, whereas in exon 19 deletion, it's far from the unity. So though overall the response rates and you do find impressive progression-free survivals when compared to chemotherapies, but L858R seems to be a different subtype of EGFR mutant non-small cell lung cancer than exon 19 deletions.
So very well said. We should not look EGFR sensitizing mutation homogeneously. If you look into monotherapy with TKI, be it first generation, be it second generation, be it third generation, the benefit is more with deletion 19 subset, whereas with the deletion with the exon 21 subset, the benefit is far lesser than deletion 19 subset. So this we have to remember, and we will just look into the progression-free intervals in the subsequent slides. Next slide. You can see that in this meta-analysis, clearly exon 19 does better than exon 21. Therefore, even the EGFR is a heterogeneous population. We cannot generalize the results. Okay, next slide. So there is a significantly reduced risk of disease progression for exon 19 deletion versus L858R, that is exon 21. Okay, next slide. So this is a very interesting data. I just saw in the chat that the ROS1 mutation, we found another T790M. So the ROS1 around 22% of times coexist with other mutations. Similarly, you can see exon 21 usually has concomitant mutations existing. So if you look into the presence of concomitant mutation versus absence of concomitant mutation, if the concomitant mutation is absent, they do better than being present. So, Dr. Satya, also in your clinical practice, have you come across such exon 21? Even though if we do a PCR, we will miss them out. If we do a NGS, definitely the chances of picking them are higher and we can better stratify them. So, any such experiences of concomitant exon 21 or just we were seeing ROS1 mutation existing concomitantly?
Yes, in fact, I have recently had two cases where we found with the L858R, the TP53 was coexisting. So that makes me realize that, okay, now this patient has coexistent mutations, and therefore, though I may jump on to use a third generation or a second generation EGFR as first line, I need to also realize that the response might be short-lived or might not be as durable when you have these concurrent mutations happening. Now, what's also important to understand is that the exon 19 deletion, when you look at the 3D structure and the L858R 3D structure and the first generation EGF like erlotinib comes, it's able to more easily adjust and optimal concentrations to inhibit the activity of an E19 deletion 3D structure are much lower for a E19 deletion than for a cell having a L858R mutation. In fact, that was one reason why, to optimize the concentrations of the drug levels reaching the tissue levels to the 3D structure, when you are able to normalize the vascular by using the anti-VEGF antibodies like ramucirumab, you are able to possibly nullify the negative impact of an L858R. So more drug can reach the L858R area and then inhibit that as it was otherwise inhibit exon 19 deletion. So there is a difference in the spatio-temporal temporal way the L858R mutation works versus E19 deletion works, though the end result is the same.
So that's perfect. That's the probable molecular basis why we are seeing differential effect. Exon 19 monotherapy with TKI is good enough. Third generation, second generation, we can argue. The moment you come to exon 21, a monotherapy with TKI doesn't do that well. Therefore, you need to have something else. And in this, as Dr. Satya said, VEGF-R inhibitor really improves outcomes. Okay, next slide. So again, this is the same slide saying that the tumor mutation burden is higher in the L858R, saying that a monotherapy with TKI will not be the way to go in the exon 21 subset. Next slide. Okay, Dr. K, so we just saw the patient with a heavy disease burden in a 49-year-old male with an exon 21 mutation. We didn't do an NGS. Maybe if we would have done, we would have picked up other mutations too. So what would be your choices in your mind when the patient is in front of you?
I think we all need to understand we have multitude of choices from osimertinib to afatinib to erlotinib. All of them are like category 1 recommendations. And then we have the choice of using a TKI plus chemotherapy, including our own TMH study. And on top of that, now we have the relay data, which talks about using the anti-VEGF receptor antibody ramucirumab plus erlotinib. So we have multiple treatment choices, but it's the relay study which actually made me look and understand that the L858R patients should be looked at differently when compared to E19 deletion patients. So you had first lung cancer, then non-small cell, small cell, then squamous and non-squamous non-small cell, then adenocarcinoma, then you had mutations, and in EGFR now you have E19 deletion, L858R. So if the patient does not mind to come for inpatient hospitalization for a couple of hours, say for 3 or 4 hours, for the ramucirumab infusion, I think ramucirumab plus erlotinib at this point of time gives us a very impressive median PFS of something like, say, 19.5 months. Having said that, if the patient says that it's tough for me to come for an IV infusion, I would then put him on a single agent EGFR TKI. But otherwise, if convenience and affordability is set aside, my tilt would be to use ramucirumab plus an EGFR TKI like erlotinib for patients who are L858R mutant EGFR mutation non-small cell lung cancer.
So that's very well put, sir. So we will just discuss the same what you have said in the slides. Okay, next slide. So you can just clearly look into the upper row and the lower row. The upper one is the exon 19 subset. You can see very impressive numbers. The flora is the best data we have. 21 versus 14. Look at the difference. Similarly, you can look into any TKI. There is a lot of difference between the PFS of exon 19 and exon 21. Therefore, if you look into the median PFS, it comes out little inferior. But if you look into the ERLO-RAM combination, the PFS is excellent and it is the best what we have seen. This is because in the ERLO-RAM combination, the PFS is maintained both in exon 19 and exon 21. Okay, I will show in the next slide. Okay, next slide. Okay, so we did counsel this patient. We offered an EGFR TKI with a VEGFR inhibitor, that is ramucirumab, in this patient, and the patient agreed. We explained him the PFS, the toxicity, and the progression-free survival, and of course the chemo-free interval for this patient. So, Dr. Satya, what is that you will counsel when you are giving ramucirumab in this patient, or what all things come into your mind while explaining the toxicity for this patient?
So I think all of us clearly understand now that we are giving the patient not one but two drugs, and therefore you will end up having additional adverse events. The best part has been that the safety profile of ramucirumab and erlotinib has been consistent with that of the individual treatment components. They don't add up, and in fact, you did not find any new safety signals in the relay study. So you might be able to end up with, say, to the patient you explain you might be having some bleeding events, some hemorrhage events. Do look out and look at your high blood pressures regularly and inform us the readings. And once in a while, I might ask you to check for the proteinuria and also look at the LFTs. But by and large, overall, majority of the patients would be able to sail through comfortably. Now, here I would like to also explain to say the residents out there that the dose of ramucirumab, as we know, say for instance, in lung cancer is 10 mg per kg with docetaxel every 21 days, or 8 mg per kg every 2 weeks. For example, weekly Taxol in stomach cancer with fulfilin colon cancer. Now here, the dose is 10 milligram per kg every 2 weeks and not 10 mg per kg every 3 weeks. Now, when this study was designed, the choice of the RAM dose in a relay was informed by the exposure response findings, which they saw from prior randomized second-line phase 3 ramucirumab studies and also the PK simulations from level studies. And they found out in non-small cell lung cancer, you could actually go to 10 mg per kg every 2 weeks. And that would help more drug be given without increasing the adverse event profile. So ramucirumab 10 mg per kg every 2 weeks is at this point of time the highest dosage of ramucirumab across all cancers. And that was proposed because of these findings. And fortunately, they did not land up in any troublesome adverse events.
So that's very aptly said. The dosing in different regimens in different organs and 10 per kg 2 weekly is unique for the relate trial. Okay, next slide. So this is the classical trial study design. Just a garden variety of non-small cell lung cancer, 19 or 21 performance status. They did exclude T790M. They excluded prior TK and they excluded brain metastasis. It was a phase 3 trial, total number around 450 around patients, 1:1 randomization. Erlo-RAM, 10 per kg 2 weekly until progression. The primary endpoint was PFS and overall survival, and secondary endpoints were safety and so on. So the stratification was based on the gender and the exon 19 versus 21 subset, the region and the EGFR testing method. Next slide. So
Chandrakant, can I just talk for a minute?
Sure. Please go ahead,
If we can go to the previous slide, because you focused about the EGFR testing methods. So I think that's important for all of us. If you can go back one slide. As you can see, the stratification factors, EGFR testing method, Therascreen, COBAS versus others. And this was what you also brought out in the initial part of the panel discussion. So they found an observed PFS difference in the hazard ratio between the patients locally tested for EGFR, Therascreen, COBAS versus other methods. Now, this remains an unexplained phenomenon because various analyses have shown that they were not able to find any explanation for the observed difference. And therefore, this finding is a random chance. In the subgroup plots, if you see, they found EGFR testing by Therascreen COBAS patients fared better. Hazard ratio was better than patients with other testing methods. Having said that, there is evidence of a PFS treatment benefit in patients whichever testing was used. So identifying the EGFR mutation is important by whatever method. If you find out the mutation, this patient should go on with the EGFR TKI plus minus RAM or chemotherapy or anything else. Please go ahead.
Very well put. So we have to pick up the mutation. That is what it matters. Okay. So next slide. So these are the baseline characteristics. What I would like to make you focus on is the EGFR mutation types. 19 is a 55%, 21 is 45%, significant number, and this is what we see in practice too. Next slide. So this is the impressive progression-free survival. For the first time, we are seeing this impressive progression-free survival of 19.4 months versus 12.4 months in the overall population. Next slide. So both in exon 21 and exon 19, we are seeing impressive progression-free survival. So probably this is the reason why this combination in the overall population and in the exon 21 has the highest progression-free survival. So, Dr. Satya, so if you look into this trial, they have excluded brain mets. So, have we picked up the best sort of population, and is that the reason why we are getting this impressive results, or is it because the exon 21 has done equally well to that of exon 19?
So I think that's a very important take-home message, that if your patient has a CNS metastasis, then you should not put this patient on erlotinib plus ramucirumab. So CNS metastasis was an exclusion criteria in the relay trial, and therefore, as you rightly mentioned, sir, it enriched the patient, the population for better prognosis. Having said that, the same criterion also has been used in other trials like the Archer 1050, the Belief, or the J025567 studies as well. And when you look at erlotinib in practice, and you choose a first generation EGFR TKI for any of your patients of non-small cell lung cancer, you would like to exclude the presence of CNS mets by doing MRI of the brain baseline. So I think it tells us that if a patient has brain metastasis, don't choose erlotinib plus ramucirumab. Now, Kumar keeps telling us in his talks also that whenever you look at a study, also look at the comparator arm and see how well or how bad it is doing. Now, in this trial, erlotinib with a PFS of 11.2 and 12.5 months respectively in patients of exon 21 and E19 deletions has done the way it has done before in numerous past trials. So the comparison arm, the control arm, did as well as it was doing before, and adding ramucirumab gave us a big delta of advantage. And that speaks that the addition of the drug was responsible for causing the difference in the PFS, whether it's E19 deletion or E21 point mutations. So ramucirumab addition makes the difference to erlotinib, and that improves the PFS.
So excellent points. I think the take-home message, it is not because of the selection bias, it is because the regimen is effective in both the subsets, and that's the reason we are gaining this difference. Okay, keep moving. Next slide. The patient improved, had grade 2 diarrhea. We could control conservatively. He had a bit of blood pressure 140/84. Next slide. So this is the erlotinib-induced rash we had that correlates with efficacy, and had grade 2 diarrhea. We conservatively managed. Urine protein was 1 plus glucose, 1 plus grade 1 transaminitis, and the BP was little high. Next slide. So we continued on erlotinib ramucirumab. It was just grade 2. So we managed with these moisturizing lotions and Lomotil, and we added an antihypertensive, was well controlled. Next slide. So clinically at 3 months, complete resolution of cough, hoarseness, and hemoptysis, which he had a little bit initially, and the weight gain was by 3 kgs. Appetite improved. Response evaluation was done at 3 months. Next slide. So you can see that there is almost complete resolution, metabolic resolution, and there is a partial morphologic resolution of all the target lesions. Next slide. So he's continued on relay regimen, and we are monitoring blood pressure, proteinuria, rash, and diarrhea. So for exon 21 subset, no brain mets, erlotinib plus ramucirumab with the doses becomes the ideal regimen. Dr. Satya, last thoughts, and we can conclude.
Okay, so excellent. I mean, like your patient is extremely well and getting a almost complete response is truly one of the best satisfactions within clinical oncology practice. Having said that, my take-home message to all the residents and my students out there would be that this combination gives us a 1% complete response rate, and this patient is that 1%. 75% of patients have partial responses. So 76% is the overall response rate. 19% of patients have stable disease. In 4 of the patients in the trial, they could not even, therefore only 1% of patients progress. So using the combination of RAM plus erlotinib, 1% of patients only have progressive disease. So a vast majority of your patients end up having a good partial response, or which is 76%, or stable disease in 19%. So 95% is the clinical benefit rate. So you put your patient on this combination. If the patient doesn't have CNS metastasis, if it's L858R especially, I think these patients stand to benefit the most and get a median PFS of 19.5 months. Very quickly, 4 limitations therefore with this study. Number 1, CNS metastasis is an exclusion criteria. Number 2, this study was not powered for subgroup analysis. Number 3, at the time of progression, patients were told to discontinue all study treatment, which is not the case in clinical practice, because if there is progression somewhere, you control and continue same treatment. And lastly, the patient's comfort. The problem is the patient has to come every 2 weeks for a IV infusion. Barring these 4 points, this is an excellent combination to use. Liberally dose modify from 10 mg per kg to 8 mg per kg to 6 mg per kg to 5 mg per kg, depending on the adverse event tolerance. Now that's for ramucirumab. For erlotinib, 150 mg, 200 mg to 50 mg. Thank you so much. Thanks a lot, Chandrakant. I learned a lot.
Thank you.
Excellent case you presented, and all the points of the relay trial you covered in your talk.
Thank you. Thank you. So thanks for the opportunity. Back to you, organizers. Thank you. Thank you, sir.
Thank you so much, sir. Before we move on to the COVID-19 and ASCO session, we have a short video from one of our supporters. So we'll move on to the last part of the day. The session will be on COVID-19, ASCO in India. Our speaker is none other than Dr. Purish Parikh, who's a medical oncologist and hematologist from Mumbai. Over to you, sir.
Thank you very much. And it's been just a wonderful bouquet of topics and data that was presented all throughout. Without wasting much time, I'll start with the outcome of COVID cancer patients N3C collaborative groups presentation at ASCO. Essentially, it was almost 400,000 patients, 398,579 patients, of which 63,413 were COVID positive and 335,000 were COVID negative. The take-home message is clearly that both death and invasive ventilation requirement was significantly higher in cancer patients who were COVID positive as opposed to COVID negative. And the hazard ratio was 1.2 with a p-value of 0.001. So all of us should go home with a clear message that if a cancer patient becomes COVID positive, the risk of invasive ventilation or death is significantly higher. And that was the conclusion. The way to identify patients with increased risk was older age, male gender, increased comorbidities, and the presence of hematological malignancies. Now, what happened to India in the first wave? So the first wave, the first case in India was identified on 30th January, and we know exactly what happened. But this has been published recently in JCO Global Oncology from the data from Kolkata. And this is data from the first wave. So if you concentrate on the red arrows, as far as radiotherapy is concerned, there was no problem with priority level 2:1 given to our patients. So those who are prioritized, absolutely no problem. But for those who are given a priority level of 5, the problem is very significant, as you can see here. As far as the chemotherapy is concerned, it was with the intent of treatment was palliative. Then there was a problem with the COVID. And the footfalls in the OPD was also dramatically reduced as soon as the first lockdown was announced, as this was the case in Tata in Kolkata for prostate cancer, breast cancer, lung, and head and neck cancer. But that was not the experience everywhere else. So this is data from Mumbai Oncocare clinics, and you can clearly see that the blue bars represent the data of the previous year when there was no COVID, and the red bars represent the data from the time when we had COVID problems. And in spite of the first peak or in the first trough, the red bars are longer than the blue bars, indicating that if you have good infrastructure, if you ensure that there is good compliance, patients have confidence, then the patients of cancer are still continuing to come for chemotherapy. And this is also the example of what happens in second tier cities. So this is data published recently by Suman Gupta of Faridabad. And here you can see that the red bars, except for 1 month of August, when the lockdown was released for Delhi, and therefore the patients from Faridabad could go back to their original oncologist in Delhi. Apart from that month, everywhere else, the patients increased as far as Faridabad and Suman Gupta is concerned. So we also all know that the second wave has overwhelmed healthcare infrastructure. And I think that is what we must prevent when we plan for managing the third wave. So how do we manage the third wave? First of all, we must understand that all our efforts are no match for the crap that is circulating from the fake university of WhatsApp. So trying to build trust in the public, trying to ensure that all decisions are based on science and to eliminate misinformation, that is not going to happen. So we should not waste our time on this. Foolish are those who expect COVID appropriate behavior from the public. Even Israel and Singapore are resigned to this fact, and therefore they have decided to do away with all these restrictions. Now, this is the perception among people who are vaccinated as to what will be their protective measures. And you can see that the perception is all over the place. You can here see on the forest plot as well that those who have vaccinated or those who have not vaccinated, not based on science, but simply on perception, you feel that whether they require a mask or not is totally inappropriate. So, what about community herd immunity? In at least in the second wave in Mumbai, the incidence of serious infections and hospitalization was much more in the more affluent community and less in the patients who were in the slums. And this was backed by data that was given out even before the second wave that says that the slums have a herd immunity and antibody levels are significantly higher, as much as 50 to 60% of patients of people. And this was also reported now after the second wave in children in the Mumbai slums. And you can see that about 50% of these people, anywhere from the age of 1 year onwards to 18 years, is more or less the same. It is ranging from 47.33% to 53.43%. So clearly, it could be that if the third wave comes and we have the fear of children being affected, there will be a significant portion of patients, at least in Mumbai, who will be protected from the third wave. Now, what about variants of concern? So this is an article that was published in NEJM on 7th of July, just a few days ago. And this is from Venkata Vishwanath Erada of Emory University and Benjamin Pinsky from Stanford University School of Medicine. And they focus primarily on the Delta variant, which is common in India. And they said that the variant was 6.8 times less susceptible and 2.9 times less susceptible to the neutralizing antibodies. Fortunately, the protective immunity conferred by the vaccine is retained irrespective of the susceptibility to the antibody. And therefore, the official position for the variant in India is that transmissibility is increased by 64%, hospitalization is increased by 85%, but there is no change in the test accuracy. The risk of reinfection after natural exposure is reduced significantly, and the benefit of vaccination continues irrespective of what variant we are talking about. This is not just through the hat, there is actual hard evidence and data. This is data that was published recently from Gujarat about the genomic variation in SARS. And this was also correlated with the variation seen across the world. You can see the red pie diagram in Gujarat, which correlates very well with the same one in North America, but is quite different from India. So India, with a population of 1.3, is not one country, it's many countries. And we have to be conscious about what happens to the variations. And this is clearly shown here. If you focus on the red arrows versus the green arrows, you can see that the p-values are significant for these three. And the top two were higher in the patients who died as opposed to the patients who recovered. But there is a mutation that can identify a better chance of recovery, as shown with the green arrow. The Delta plus variant is also coming into the picture. Now the 50 cases have been identified in India so far and 4 deaths have occurred. So targeting high risk individuals, what is it that we need to do? In this management portfolio or the scene snapshot of COVID-19, there are certain areas that we want to target to prevent the healthcare infrastructure from being overwhelmed in the third wave if it comes. And what are these high risk patients? It's very clear and very easy to identify them, like comorbidities like asthma, hypertension, obesity, diabetes, chronic kidney disease, severe obesity, BMI of more than 40, or if having more than one comorbidity or 3 or more conditions. So based on this, we all know that cancer patients will have a risk of at least 3 times the normal population, or more likely to be a 4.5 times risk. So we really need to identify the early symptomatic patients during the third wave and ensure that they do not require hospitalization. And the idea to do that is by monoclonal antibodies. And now we have in India available from an Indian company, Casirivimab and Indevimab. So antibody cocktail to prevent the need for hospitalization is clearly the way that we have to prepare ourselves when we are thinking of the third wave. And the third wave could really be there because already we are seeing the consequences or the effect in Thailand, in Indonesia, in Israel, and in United Kingdom. So what are these antibodies? These antibodies target different binding sites which are non-competitive on the cell surface of the virus. These therefore prevent the entry of the virus into our body, and therefore they protect also against emergence of resistance. Now, this is an article published in New England Journal of Medicine on 21st January 21 about this cocktail. And this was the patient disposition here. You can see that 80 patients completed trial on placebo, 80 completed trial on the 2.4 gram dose of the cocktail, and 84 completed the trial on 8 grams of the cocktail. And if you look at the what happened to the viral load of these patients who are having COVID positivity but not hospitalized, you can clearly see that the treatment with the cocktail reduces the viral load significantly as compared to the placebo, and this is seen for both the doses. Based on this data and other data, this combination has been approved for use by as many as 13 countries, and CDSO in India also approved this on 3rd May 2021. So what are the indications? Any person, any child or adult who is more than 12 years of age, any person who is more than 40 kilos in weight, who has a COVID positive lab test within 10 days of COVID-19 symptoms, currently not requiring oxygen, and at high risk of severe COVID, which is therefore applicable to all patients with cancer who become COVID positive. The dosage is total of 1,200 milligrams, 600 milligrams of casivirimat, and 600 milligrams of imdevimab, both given together in the same IV infusion solution or individually given subcutaneously at sites which are 2 inches apart, as was shown in the video that you saw. The effect of this is equally good among the variants, whether you take the original UK origin, South African origin, Brazil origin, and so on and so forth, as well as the Indian origin. There is no change as far as the efficacy of these antibodies are concerned. In fact, the recovery study has started evaluating this even in patients who are admitted to the hospital. And clearly you can see whether, though in all participants the difference is not statistically significant, if the patient is seronegative, that means there were no protective antibodies, and you're giving this antibody cocktails, these patients do exceedingly well with the treatment. And this is the advantage. Earlier we saw the data for patients who are not hospitalized, so prevent hospitalization. And this is the data about the survival of patients who are seronegative and benefit from this antibody cocktail. And if you can see the forest plot again, the 2 red arrows see the outcome which is less likely if the antibody is given, that is less likely chance of death within 28 days and less likely chance of invasive mechanical ventilation. The green arrow says the outcome is more likely with the cocktail, and that is discharge alive from hospital. So clearly there is evidence that this is statistically significant and a significant hazard ratio as well. So finally, the take-home message, we have to be prepared for the potential third wave. Perception among the public change is not possible. Let's not waste our time on it. Community herd immunity does help, as has been seen or experienced from the slums of Mumbai. Variants of concern are not so much of a concern. We should be assured that everything will still work out. Targeting high-risk individuals is the best solution to prevent our infrastructure from being overwhelmed. An antibody cocktail is gaining momentum both for patients who are early diagnosed with COVID positivity as well as for hospitalized patients. With that, I thank you all for a patient hearing, and we should all remember to be better safe than sorry. I hand it over back to the organizers.
Thank you so much, sir, for the wonderful session. Before moving on to the last part of the session, we would, on behalf of Dr. M. Vamshi Krishna and the organizing committee, we thank our scientific committee advisors. Thanks to their support, we were able to choose the best abstracts for the conference. special thanks to all of them.